We are live now.
Good morning, friends. On this 4th of September, on Sunday morning, on a pleasant Sunday morning, we welcome you all to a webinar on a very important topic, the forearm fractures, management of forearm fractures, especially the complicated ones, the role of plate versus nail, and the various aspects of managing complications and dealing with the difficulties in managing forearm fractures. We are fortunate we have galaxy of faculties today with us. They'll be taking us through various topics. At the outset, I would just like to welcome our President of Maharashtra State Orthopedic Association, Professor Wasudeo Gadegone. Gadegone sir, welcome and please address all of us.
So, good morning to everybody, viewers of OrthoTV and esteemed members of Maharashtra Orthopedic Association. This webinar is designed to acknowledge you all about the progress of a conference at Goa. Dr. Sunil Kulkarni and Dr. Shaikh will give you a brief presentation how the works are going on in the Goa conference. I request you all members to register for this very magnificent this scientific bonanza on 6th, 7th, 8th, and 9th. We have made all workshops complimentary, those who will be registered for conference. I request on behalf of the organizing committee, Sunil Kulkarni, Shaikh, Dr. Karne, and myself, that all you should register for this a prestigious conference. So over to Dr. Sunil Kulkarni.
Good morning, sir. Thank you. And I welcome this. I'm just giving a few minutes so that Samir can share his screen later. This year, this MOACON will be a different one because we are trying to change the scenario of MOACON so that the visiting delegates get maximum experience of workshops, different workshops. Like we have 8 workshops actually on go. One is one by Synthesis will be a demo workshop, but they also have the sawbones and coming with. So that these workshops are very popular all over the world. The AO, if you remember, AO courses are mostly full because of the workshops. So workshops are real way of teaching, and that is the reason we are giving more workshop rather than giving didactic lectures. And also the main sessions also, Samir will show you the outline how we have planned it. Each and every session has got very small talks, and entire half an hour to 35 minutes will be spared for cases, so that the panel, the delegates, the faculty will share their experience, and the conveners will continue to give a good message. So each and every section has a good message, a common topics, as well as we are now adding to robotics also in the sessions. So it will be a basic as well as the advanced, and there will be a video session by the stalwarts, so that the videos will be shown with the international faculty and our national faculty also. So, and basically we need a lot of registrations, because unless we get a lot of registration from our own MOA people, executive body, and request the president, secretary to encourage the registrations, so that we will feel better if we get more delegates, so that more the faculty will be also easy when they see the number of full chairs rather than empty chairs. So I thank you for this, and I hand over to Samir. Samir, you can share your screen and give the details.
Yeah, first I would like, just before sharing the screen, I would just like to highlight what we have done up till now. Just a minute. It's not getting shared.
By that time, we welcome Dr. G.S. Kulkarni onto the panel. Welcome, sir.
Dr.Pramod from Maharashtra Orthopedic Association, Vice President, also joined.
Yes, he has also joined. Welcome.
Samir, you can talk. You can just
yeah,
tell.
I can talk. Yeah. So regarding this, Now, as Sunil sir said, am I audible to everyone?
Yeah, you're audible. If you want to
Yeah.
share your
So-
screen, you can share your screen.
I'm trying, but it's not
Share.
coming. Okay,
Yeah.
let's. So
Okay.
I will just highlight the program and our registrations, how much we have got up till now. So first of all, if you see, I welcome everyone for this webinar, and for 6th, 7th, 8th, 9th of the October, I expect from all the members to motivate all your colleagues as well as your members to register first for the SDOA, this program what we have done. And then I would like to suggest ki now at present where we are just. So about registrations, if you'll see about registrations now, already now we had 180 rooms registered up till now. So 180 registered means almost if you see 400 registrations has been done. 200 abstracts we have received, 230 abstracts we have received up till now. And for out of 230 abstracts we have selected at present registered members are out of this only if you'll see are 130 registered members. So yet we have given a deadline up till 10th of this September. If they register before 10th, then we are going to take them inside, right, for the paper presentation. Otherwise, we are going to disqualify them. So at present, 130 registrations for the abstracts has been done. But out of these paper presenters, if you'll see, only best papers we have received are 17 best papers we have received. Out of 17 best papers, only 6 people have registered. And 9 people has not registered. So we are waiting up till 10th of this September. If they get registered up to 10th, then we are we will welcome them. Otherwise, we are going to disqualify them. This is about abstracts. Registration, as I said, up till now, if you see on paper registrations, we have received almost up to 400 registrations we are having at present, we can say. Non-residential registrations are including in this. So we are expecting residential registrations more for this. Let's see, and in this last month, how much we can progress. Now, about registrations, I have given you the details. About abstracts, we have given you the details. Now, very important thing, what I want to discuss is about the scientific program. So scientific program, if you'll see, as you all know, it's on 6th, 7th, 8th, and 9th. So 6th, we are having first, if you'll see on 6th, initially we have kept 3 workshops on the 6th of this October. 6th workshops, 3 workshops are, one is for Sorat, that is suprapatellar tibial nailing is there. Second one for orthotech, what we have kept, that is for total shoulder arthroplasty. And third workshop is from the bone tech, if you'll see, that is of the proximal humerus plating, that is their humerus plating. So these 3 workshops,
periprosthetic shaker.
Periprosthetic fractures, sorry, periprosthetic fractures plate, what they are having, that is of bone tech. So these 3 workshops, all 3 workshops are of 1 hour each. Like 2 to 3, 1 workshop is there, 3 to 4, another workshop is there, and 4 to 5, third workshop is there. And 5 to 5:30, we have included one guest talk, that is from UK, Dr. Chidgupkar, or he's a spine surgeon practicing over there. And our MOA members, us, are having a privilege to go there and do a spine fellowship over there. So that Dr. Chidgupkar is going to talk 20 minutes about opportunities in the UK for the spine fellowships. And second thing, again, he is going to what doesn't change in the spine. This is the
Samir,
talk.
Samir, sorry to interrupt. So these are very good programs. I think it would be better for everyone to visualize all those things because it would go.
We will send it on group also, sir.
Yeah. So can you be ready with the presentation at the end also? We can take it up.
At the end, just one talk, you can finish it. I will share this.
Yeah, by that time we can keep ready so that because everyone gets the right information, everyone gets a pictorial information.
Okay, right. One just talk, you finish it, I'll just share it.
Yeah, that's fine. So
let him complete, sir. Let him complete, then he can show it later. Let him complete. He can talk and just because again it will link talks when you what talk, Samir, you're talking about? The talk means forum talk.
Forum talk, one talk, if they can complete, we will again join.
Again, you have to rejoin again, probably.
Okay, so you can just try sharing right now.
Yeah, I will
try 1 more minute.
Yeah, just try sharing.
If not, then we can continue to without wasting time.
Yeah, no problem. Just try one. I think you'll be able to share. Just press on the.
I'll share, sir. You continue with one talk. I will share after this.
Okay.
Dr. Karne is going to speak about that MOA. That what?
No. He is busy in some program. So now he will straight away go for webinar.
Okay. So thank you, Samir. Thank you, Dr. Sunil Kulkarni, sir, for giving us the briefing about the MOACON. And it is going to be an excellent academic bonanza, as you said. We all are looking forward to that great program. And shortly, Samir would be detailing us about all the program details. We'll actually get the brochure, etc. I welcome Dr. Sangeet Gawhale, Sangeet, myself, Dr.R.M.Chandak, and Dr. Shinde will be taking you through this webinar. It's a very important topic on forearm fractures. And let me welcome for the first talk, Dr. Ajit Phadke, sir, who hails from Yavatmal and has a large volume of experience on managing forearm fractures. He also has designed, along with Dr. Kulkarni from Amravati, Kulkarni Phadke distractor, which is very popular for forearm close nailing, which helps us in getting a close nailing procedure done easily. So welcome, Dr. Ajit Phadke, sir, for your talk on tips and tricks in nailing procedures.
Thank you, Dr. Chandak. I thank MOA for giving me this opportunity to speak on tips and tricks. Is my screen visible?
Yes, we can hear you and the screen is visible.
Okay. So today there are only a few tricks, but a lot of tips. There is no trick in orthopedics. The only trick is to get good results, and that will make you successful. A close forearm nailing, though not universally accepted as a method of treatment, is, in my experience, a very good way of treating forearm fractures. And I'll only be giving you tips, the detailed procedure, and about complications, Vidisha will be handling. Now, this Campbell Operative Orthopedic Strength Edition says that for many fractures of radius and ulna, either a plate or an intermediate nail is satisfactory, and the choice is determined mainly by the training and experience of the surgeon. So you need not feel guilty that you are nailing a forearm fracture and not plating it as advocated by AO. The first tip is you should choose your battles. Not every forearm fracture is nailable. Just because I'm propagating nailing, it does not mean I nail all the fractures and I don't do plating at all. But you should select which patients you are going to nail so that your results are good. It is indicated in diaphyseal fractures of radius and ulna with at least 5 centimeters of intact proximal and distal bone. Because without this intact bone, it is not possible to get a good hold and a good entry point. The compound grade 1, 2, 3A open fractures can be treated by nailing very well after debriding the fracture. Unstable displaced fractures and segmental fractures, especially segmental fractures, are very suitable for intramedullary nailing, where you don't have to do a lot of dissection to get plates across both the fractures. Monteggia or Galeazzi fractures are a special indication where you can attempt close nailing after you become an expert in close nailing. Initially, it is better to plate these fractures because you have to get the articulation exactly correct and reduction anatomical to get good results. But you can do it if you are an expert. This is contraindicated if the fractures is at the extreme end of the bone. It is contraindicated in grossly comminuted fractures where there will be a collapse of the fracture and the nails are not interlocked. So you can't pull out the fracture to length. Bone loss is another indication, contraindication for intramedullary nailing. Narrow medullary canal, open grade 3B, 3C fractures or old fractures where you will not be able to do a close nailing is a contraindication. Now, the important tip is you have to prepare. If you prepare, you will succeed. If you don't prepare, you will fail. A full-length X-ray is necessary because you have to see both the joints, the proximal and distal fragment joints, You have to look for comminution. You have to see whether it is segmental. Diameter of canal is most important because you should get at least a 2.5 millimeter nail inside the canal to get some stability of the fracture site. Radial ulnar joint injuries usually are a contraindication for nailing, usually I said. Nail length determination is done preoperatively and you should have the whole uh, assortment of nails available. Diameter determination is more difficult with digital X-rays. This is the small trolley that you need, not a big issue. Now, without using a distractor, it is very, very difficult to get closed radius ulnar nailing and you'll be frustrated by your attempts. So use this simple distractor which we have designed. We don't get any royalty out of this distractor. Kulkarni and I designed this distractor way back in 2001 and we presented it to MOA in 2005. This is how it looks when it is assembled, and you can see the whole forearm is free for your intervention. If necessary, you can also open the forearm with the distractor on. This is how the CM can be visual, or you can visualize under the CM in 2 axes. You should ensure reduction before nailing because you can use this distractor to get alignment also, and also the length of the forearm bones. And you can control the rotation also by the fly nuts so that you can get a good reduction. This is an important tip. When in lightweight patients, sometimes you might have to pull the patient down to get good traction. Otherwise, the patient keeps on moving up if you are giving traction to the forearm bone. The rotation of the forearm can be adjusted from prone to mid prone. Most of the times, the prone position, you can get a good reduction. You should take correct entry point. This is the important tip. Now, when those of us who have from the old school, we have done open radius and ulnar nailing, and we used to use this Lister's tubercle entry point for nailing. This is not the best entry point for a closed nailing. We use the styloid process as the best entry point so that you get a 3-point fixation and your nail can be manipulated more easily. This is the bone is subcutaneous here and only a few tendons are there. So you have to use your artery forceps to see that you're not hurting any tendon while doing the entry point. You start with a bone awl, which is a small bone awl, so perpendicular to the bone, and then turn it upward or to the direction of the canal. So once your bone awl enters the direction of the canal, the nail follows very easy. This is an important trick. You don't have to use any drill for starting the entry point. In the ulna, previously we used to do the olecranon entry point, but now we recommend a medial entry point as marked on this film. You see the tip of the olecranon is spared. So this prevents backfiring of the nail. Otherwise, during healing, sometimes the nail backtracks and then you get a big bursa on the ulnar entry point. The ulnar nail entry has to be on the medial surface of the olecranon. Which nail to choose? Now, we started with the square nails or Talwalkar nails. I now regularly use rush nails. Dr. Kulkarni used Lamvinity wires. I have also used titanium elastic nails in those patients who can afford. Screw nails have been used by Gadegone successfully. So you have got a choice and you can use whatever you want. The important word in this is close nailing. If you can get it closed, then your nailing is going to be successful and the correct diameter. If it is too thin, then your nailing might fail. If it is too fat, you might get jammed while you're nailing. The correct length obviously is important. This is an important trick that is before you start nailing, the tip of the nail should be bent. Now this gives you a good access while crossing the fracture. So you can rotate the nail to either this side or that side and find the distal medullary canal. Now, which bone first is the question which many people ask. So my choice is radius is first because it's a curved bone and not subcutaneous. So it's slightly more difficult than the ulna for nailing. And so it is better to do it before the ulna is fixed. The second bone after fixing the first is usually slightly more difficult, and ulna being subcutaneous makes life more easy for nailing the second. How do you cross the fracture side? Now, as you can see, the nail tip is bent. So if you find that your nail is going outside the fracture side, you can turn the nail around and enter the medullary canal correctly. What is important in this is not to keep on shooting or seeing the C-arm live, because otherwise you will burn your balls. The better thing is to feel. You don't look while you are nailing. The ulnar nail passage can similarly be done after the radius nail has crossed the fracture. Now you can see over here, we are stopped after crossing the fracture for about 1 centimeter. We don't progress continuously till the nail is completely fixed, so that some play is still there and you can get the ulnar fracture reduced very easily. Now this translation can be corrected by a simple push with your finger, and you can cross the fracture side. If it is still not possible, you can put a K wire inside the fracture site under IITV control and use this as a lever to get the fracture in line. So see, this is how the lever works, and then you can cross the fracture. These simple tricks you can learn very easily once you start doing the procedure regularly. For a novice, it might be difficult. Now, once you have crossed the fracture, you should release the traction before further progress, because this allows compression of the fracture while you are impacting the nail. The nails are advanced after the traction is released. This is important because you have a hammer in hand. Do not use force while driving in the nail. The nails should pass smoothly. If you use a force with a hammer, you might split the fracture, or especially near the fracture, you can create a butterfly fragment. And sometimes, if your diameter is not correct, you might jam the nail, in which case it is very difficult either to remove it or to put it forward. So if you jam it, then it becomes very difficult if you are hammered. If it is not hammered, you can easily remove and put a smaller size nail. Once your nailing is over, you should screen the whole length of the forearm. This avoids mistakes. You can see for the rotation. Now, how do you see the rotation? This is also important. If both the cortices are parallel to each other and the diameters of the bone are equal on both the sides, that means your rotation is correct. Now, if there is a gap at the fracture site at the end of your nailing, you can use this simple procedure for thumping and bringing the fracture or closing the gap. If you leave a gap, then chances of non-union are more. Now, if there is a discrepancy in the canals of the fragment, there might be persistent translation. So in this case, you put a smaller additional nail. Like here, there is some translation remaining at the end of nailing. So you put another additional nail by the side of the first nail and just cross the fracture side. So you have corrected the translation very easily, and you don't have to worry about the alignment or the anatomy. In special situations like the Galeazzi fracture, where there is a radioulnar joint dislocation, or here there is always a discrepancy in the canal side. So it is better to use a pre-bent nail or a stacked nail. Like you can see the first nail is bent, and I have stacked the nail with another nail so that there is no translation. You can see the radioulnar joint is perfectly aligned. Now this is a bit more difficult, so I would advise only to do this if you are an expert in nailing. This is a case from Dr.Chandak where he has stacked nails to fix the extreme ends of the bone. Now this is again something that you can only do after you are an expert in nailing. You should not try such tricks in your initial phases. Post-operatively, it is easy. Give up above elbow slab in 90-degree flexion and forearm in full supination. Why I will tell you. Active mobilization is started and stitch removal on 10th day. The AE plaster cast in supination I give for 4 to 6 weeks. Now, why always in supination? Because Otherwise, supination takes a very long time to be regained by the patient with physiotherapy, and he is worried whether he's going to get supination. Ultimately, they do regain. But if you have already kept the forearm in supination, then there are no problem with the supination. And pronation can be compensated by trick movement, that is by abducting your shoulder. So the patients are not bothered about loss of pronation. They are more bothered about loss of supination. So always give above elbow cast in supination, whatever the region of the fracture. It is not that middle third you give in mid prone, distal third you give in prone position. That was only for close reduction. Your nails are inside to keep your bones parallel. Also in supination, the interosseous membrane gets stretched, and so chances of getting malunion are less. Now, cast removal is done at 4 to 6 weeks, followed by X-ray, and start using the hand. And if you are not fixated on plating all your fractures, then I'm sure once you start nailing, you will save a lot of money, you will save a lot of time, a lot of frustration, and your patients are going to be very happy. I thank you all for giving me a for following my talk, and I hand over the mic to Dr. Vidisha to continue with the same topic, that is forearm nailing. She'll be talking about complications and other aspects of nailing. Thank you very much.
By the time,
Thank you, sir.
yeah. So, Sangeet, any thought process? GSK sir, if I can ask you, your philosophy in forearm fractures for nailing, you would recommend it, you would advocate? You are muted, sir. Sir, you are muted. GSK sir, you are muted.
I don't think I can add anything to what Ajit has said. Yeah, absolutely. We are using routinely forearm nail, in spite of AO and the whole world is talking about plating because of the bowing of the radius, and the interosseous membrane is not maintained, they come together, and so on and so on. But our results of using nail instead of plate are really good, because it is a closed method. Infection rate is very much less, almost rare. And so I feel that nailing is an ideal one. Of course, we don't use the more distal, even if Galeazzi, there I use, for Galeazzi, I use plate and put 2 K wires to prevent the further dislocation of the radial nerve, distal radial nerve joint. So put 2 K wires proximal to the joint, so that you don't pass through the joint. So these are my comments.
Thank you. Thank you very much, sir. And Sangeet, I think you will be vouching for plate in your lecture. So any quick comments from you?
Sir, the issue is the class of patients where they want to go to the office in about 5 to 7 days time. They don't want, their expectations are they don't want a plaster post-operatively. So, we cater to a different category of patients where plaster is not acceptable. It is seen as something wrong in the surgery if given post-operatively. And once you plate it, reduce it anatomically, then probably we see the patients directly. They don't come for follow-up because they are comfortable, they are able to do their day-to-day activities. So that is the difference. But in an indicated case, probably nailing would be still a good option.
Okay. Okay. Thank you. Thank you very much, Sangeet. And I hope Dr. Samir is ready with his presentation.
Yes,
so
I'll
just
share
a
my
minute.
screen.
Yeah. Please share your screen.
Yeah, now.
Yes, we can see that. Yeah.
Yes, okay. So now, as you all know, we are meeting it at Taj Convention Center, and rooms already I have told you, like more than 400 registrations now we had, other than all the abstracts and workshops. As we discussed, we are having 8 workshops. Out of 8 workshops, if you'll see, that is day 1 trauma, we are having hip femoral, proximal femoral nailing or the hip fixed nail, ortho care and cure. Arthroscopy, what we are having of Depu-Mytech, knee and shoulder, basic knee arthroscopy we are doing. Arthroplasty, if you'll see, we are doing it of hip and knee, that is Biored. Trauma, that is calcaneus plating of Nebula. And spine workshop we are doing from Parshva, that is pedicular screws. And 3 more planned on Thursday, that is Bontech, Orthotech and Sorath. We will see in details on the our Excel sheet. If you'll see this, Thursday, if you'll see, we have planned 2 to 3 p.m. Orthotech, that is shoulder replacement is there. Then 3 to 4 Sorath, that is suprapatellar nailing is there. 4 to 5 periprosthetic fractures is there, what we have kept. And 5 to 5:30, that Dr. Shashank Chidgupkar from UK, things that don't change in spine surgery. That talk he is going to give, and a 10-minute talk for the opportunities in the UK for the spine fellowship, what he is going to tell us. Other than this, if you'll see, the next day, that is Friday program, if you'll see, we are having schedule of Hall A, Hall B, Hall C, Hall D and Hall E. We will be rotating all the batches. Now, for example, if you are having a 500 registrations, so 100 persons, 100 registered delegates, they will go to Hall A, 100 will go to Hall B, 100 will go to Hall C, 100 will go to Hall D, and 100 persons will go to Hall E. And then after 1.5 hours, we are going to rotate those. For batch A, suppose the, for example, if you see 8 to 9:30, if you see batch A is there, batch A is going to Hall B for the next session. That the other batch will come to the Hall C, other batch will come to the Hall D, and then to the Hall E. Every delegate, that all workshops are complimentary for them. That's why those who are interested, they will go to their respective batches. We have made a color code. We have made for all other members, like 500 registered delegates. They will be having 100 persons. They will be having the green code, blue code, red code, violet code, and other pink code. So these codes, what we are having, that they will be having the code on their batches, and accordingly we will be distributing them for the year. So this will be on the Friday. These 5 workshops are there. After Friday, our main thing, trauma workshop, if you'll see, that is of HFN, hip fixed nail. Arthroscopy we are having of the knee and shoulder, that is Alex models. For the first time we are bringing it in the MOACON, and that we will be having for the 5 models for the knee and 3 models for the shoulder will be there. Spine instrumentation we are doing for the pedicular screws fixation, and that again we are going to demonstrate it on the saw bones. For arthroplasty, we are having the hip and knee bone models over there. We will be having a 20-minute talks, and then followed by the 1 hour workshop for that. And for the foot and ankle, again the calcaneus plating they are going to demonstrate on the bone models itself, and that will be seen by the Sampath Dumre Patil. So these workshops are there on the Friday. Now Saturday program, if you'll see, the main conference starts on the Saturday. We are having Hall A, Hall B, Hall C, Hall D, Hall E, and 1 cinema hall is there, what we are having. There we are going to demonstrate in cinema hall also. This we have kept for the first time. So if you'll see, morning we are starting at 8 a.m., 8 to 9 a.m. If you'll see, all free paper sessions are there. There in Hall A, Hall B, Hall C, Hall D, Hall E. All free paper sessions will be there. Followed by, if you'll see, there are 3 theme lectures, what we have kept initially. That is given by Dr. G.S. Kulkarni sir, Dr. Sharath Rao from the Bangalore, and Dr. Anand Joshi from Mumbai. Again, 9:45 to 10:30 a.m. we are having 3 invited guest lectures. Again, Dr. Tanna sir, Dr. Babulkar sir, and Amit is going to talk. Then we are having 10:30 to 11. If you'll see, we are having a Shahane oration that will be given by Dr. Ajit Shinde sir, or his talk on trauma. And then 1 to 11:30, that is sorry, here by mistake we have written 1 to 11 to 11:30 we are having CG Pradhan oration, that is Dr. Ramesh Sen sir is going to give a talk over there. 11:30 to 12:30 we are having Dr. Abhay Bang sir is going to give his talk, and we are going to felicitate him. AM 11:30 to 12:30. Then 12:30 to 1:30, Stu Rocha best paper session is there. 6 best papers has been selected for this session, and then that will be given by them. Parallel to this, Shane oration, CG Pradhan oration, Abhay Bang, Dr. Abhay Bang's lecture, and the Stu Rocha best paper award. No parallel session will be there in other halls for this. But other than that, we have kept all the modules which has covered all the topics, if you'll see for that. So accordingly, we are having Hall C with a pelviacetabular trauma. Hall D, we are having Elizaro session. Hall E, we are having osteoporosis session. And then in Hall C, there is infections in the spine. Operative techniques is there. Lumbar canal stenosis, the difficult IT fractures, pediatric ortho is there. Even tips and tricks for implant removal we are having. And one is missing over here, down 3:30 to 4:30 session, but one more session is down over here. So this way we have covered all the modules: distal femur, lumbar canal, IT fracture, pediatric ortho, tips implants, technical updates, proximal humerus fracture, knee arthroscopy, suprapatellar tibia nailing, operative techniques in orthopedics. One video session we have kept, as well as on osteoporosis. And in cinema hall, if you'll see, we have kept other workshops. Nebula is again demonstrating a neck femur workshop for 1 hour over there. Orthocare is going to do a compression humerus nailing over there. Suprapatellar tibia nail, those who have missed on the 6th, again they will be able to see it on the 8th, and the bone tech for the periprosthetic fractures. Similarly, now the Sunday program also we have kept. Sunday program, if you'll see again, it's a jam-packed schedule. Like if you'll see, there is a 9 to 10 AM invited guest lectures are there. Again, Hall B, injuries around the elbow is there. Hall C, demanding tibial plateau fracture, how to plan it is there. Hall D, we are having a synthesis workshop. If you'll see 3 things, what they are going to do it in there: proximal femur, proximal tibia, as well as third one. Dr. Sunil Kulkarni sir will tell you third thing what they are going to do. And for
multi-lock humerus.
Multi-lock humerus. Multi-lock humerus, one synthesis workshop is there. And in Hall E, constantly when we are having 4 halls, Hall A, Hall B, Hall C, Hall D, PGCon is going to be there in Hall E, which Dr. Srikant Deshpande and Dr. Nagesh Naik, they are going to see. For PGCon, almost Saturday as well as Sunday, 1:30 to 5, as well as from 9 to 2, PGCon we have kept it in Hall E session. And then after valedictory function, again we are having the different modules, that is difficult femur and tibia nailing, foot and ankle session, shoulder arthroscopy session is there. Women's ortho wing, for the first time we have started here, that is Dr. Tanvi Shinde, she is going to lead it, and Dr. Vidisha madam is there along with her. Health and bodybuilding, again this is very important topic. Dr. Ashish Jain and Dr. Tejas Kulkarni, they are going to highlight us on their bodybuilding and health issues. The orthopedic surgeon, again video technique trauma we have kept. Pylon fractures are there, infection in orthopedics is there, non-unions are there. And again, for the first time here in MOACON, we are introducing the West Zone Orthopedic Association case session, and Dr. Naveen Thakkar from the Gujarat, he is going to present cases from all the Gujarat as well as Goa and Maharashtra people. 6 cases we have kept it over there. Knee arthroplasty session is there. And the medical legal session as well as the office orthopedics is going to be demonstrated by Dr. Karne sir. This is the program what we are having, jam-packed schedule for 4 days is, and if anybody wants to ask about this, they are free to ask me about the program.
Thank you, Dr. Samir, for completely raising the curtain on a very useful academic session of the MOACON, and we expect large number of delegates would throng to Goa for enjoying the academic bonanza you are providing. Thank you so much. And with this, we proceed to the next lecture from Dr. Vidisha Kulkarni. She'll be taking us through advantages and complications of nailing procedure. So,
Samir,
Dr. Kulkarni, you want to say something?
No, Samir, you should.
I am unsharing. And if anybody is having doubts about the program, they can ask me as well as Dr. Sunil Kulkarni sir about this.
Yes. Thank you. Thank you so much.
If you can share, Samir, if you can share the program, so that
I will share the program, sir.
So that we can make our bookings, flight booking, travel arrangements, and also your number of registrations, seeing the program would increase.
Sure.
Yes.
And I am hoping from all the members that they should motivate their all PG students as well as their colleagues, as well as from the particular region, like from Pune, Mumbai and Vidarbha. If you'll see, there are very less registrations what we have got up till now.
Thank you so much, Sunil. Thank you so
Okay.
much.
Can you
And
see the screen, sir? Chandak
Yeah,
sir?
we can see the screen,
Okay.
and I hope Vidisha is ready with the talk on a very important talk. She is going to present both advantages and complications of nailing. Yeah.
Thank you, sir.
Yeah.
Thank you, Chandak sir and Gadegone sir, for this opportunity. Already the technique and tips are covered beautifully by Phadke sir. I will be focusing on advantages and complications of forearm nailing. As we all know, forearm nailing is an intramedullary device. It offers biological fixation by preserving the periosteal blood supply. It is cost-effective, cosmetically acceptable by the patients, and requires short period of immobilization of 4 weeks. And associated radial neck fracture can be treated with radius nail as well. It is usually done without tourniquet. There is less risk of compartment syndrome, very minor problems associated with wound healing. Closure is always easy. As Dr. Phadke sir said, we can use titanium elastic nails, rush rods, Lambrinudi wires, or stainless steel square nails. It can be used for masculate techniques or for defect non-union along with the ring fixator. It is the treatment of choice in pediatric displaced forearm fractures, especially in the older children. It requires less operative time, very less bleeding is there. Also, the infection risk is minimal unless it is a compound fracture or there is any entry point impingement or skin laceration. Very, very less refracture rate in comparison with plating group. So this 60-year-old lady presented with this kind of fracture, butterfly fragment of the ulna and comminuted A3 type of fracture of radius as she, after a trivial fall. So deciding for a treatment, as she was osteoporotic, I went for closed forearm nailing. And this is how it united uneventfully. And this is after implant removal. Even in displaced wedge fractures, nailing can be done. Here, there is a butterfly fragment of radius, proximal midshaft radius fracture is there, associated with simple A3 type of ulna fracture, both nailed and union. 1.5-year follow-up after implant removal. Nailing can be done in single bone fractures if the fracture is length stable, like this simple fracture of ulna, which was compound. So it was debrided and beads were kept along with intramedullary nail. So this is after union. Nailing can also be done in segmental fractures, can be done in compound fracture after thorough debridement. It can be used as a temporary fixation modality till the soft tissue coverage is complete, or it can be continued as definitive fixation. So this is how C2 type of fracture of radius along with ulnar segmental fracture. So this was treated with closed nailing, debridement beads, and this is how it went to union, and there was no any rotational malalignment. The patient regained full pronosupination as well as shoulder elbow function. Now coming to again segmental fracture, grade 2 type, again done with same technique, close nailing. Here C2 type of ulna is there, beads and square nails used in all these cases. This is how it united. This is after implant removal. And this is the photograph sent by the patient on WhatsApp. Bilateral ulnas can be fixed. It can be used in polytrauma patients, bilateral situations. Here the left side is having simple distal ulna fracture, whereas the right side having segmental fracture. So both the extremities were nailed by closed technique. And this is how it united on both sides. There is problem when there is narrow medullary canal, especially in pediatric patients. You can then go for a single bone nailing, like as in this patient, the medullary canal of radius was very, very narrow. So only ulna was nailed, and the fixation was protected on a AE cast in supination for a month. And this is how it united. And this is after implant removal. This is the function. But there are definitely few disadvantages and complications associated with nailing procedures, as the nailing is contraindicated in very proximal or very distal fractures associated with proximal radioulnar joint or distal radioulnar joint instability, like Galeazzi or Monteggia fractures, where you require a lens stable implant in form of plates. Union rates are high only with closed techniques, and open nailings are associated with more non-union rates. Also, distraction at fracture site is not tolerated. That leads to non-union. Many a times it is not applicable in short oblique fractures, which is unstable. Also, the nail should be properly cut underneath the and properly cut and bent so as to prevent impingement. For ulna, it should be buried under the anconeus or the muscle cover. Radial styloid entry should also be carefully done in the center of the radial styloid, protecting the superficial radial nerve as well as the first compartment extensor tendons. Another disadvantage is that more radiation exposure is there with close nailing, and really skill is required for performing close nailing. It needs good assistance or equipment as shown by Dr. Phadke sir in the form of forearm distractor. Sometimes implant removal is difficult when also the radial nail should be properly pre-contoured before insertion to match the natural radial bow. Cast immobilization is a must for all patients. This is the literature support saying that union rates with plating are approaching 100%, whereas with nailing group, it was 86% in one study. Lister tubercle entry is associated with high rates of extensor tendon injury. I have seen a few cases of EPL rupture after this entry point in out-operated patients. This is interesting case who presented at 6 months out-operated forearm nailing and whose ulna nail was removed early, and he presented after 3 months with non-functioning index finger tendon as well as non-union at the ulnar fracture. So this was revised in the form of compression plating for ulna with bone grafting, as well as exchange nailing for radius. Styloid entry nail was put, and the extensor tendon was repaired. There was attritional rupture of index finger extensor tendon, and the length lost was nearly 7.5 centimeter. So this was substituted with a palmaris longus tendon graft and suture to the proximal and distal stump with fish mouth technique. And this is how then he regained his extensor function after 3 months and regained pronosupination as well as wrist, which was previously stiff. Nailing is contraindicated in length unstable fractures like this comminuted proximal radius fracture. It was nailed. Now see, there is ulna plus. So the absolute contraindication of for nailing is length unstable fracture or comminuted fracture. Again, for proximal and distal fractures, nailing is contraindicated, like as in this patient who presented with this deformity and non-union to me, so which was played later on. Again, inadequate nail diameter with distracted fracture leads to non-union. So proper nail size is a must. If the canal is small, you have to go to plating. Olecranon tip entry is associated with high backing out of nail So nowadays we take entry point distal to the olecranon tip on the lateral or medial side, so that the nail can be buried under muscle cover. Gap at fracture site is not acceptable. So if you find gap, you better shift to plating in such cases. Improper length is not justifiable, especially in distal and proximal fractures, which is indication for plating. So the take-home message is, closed nailing is a good treatment modality for managing length-stable forearm fractures in children as well as adults if done properly. Thank you for patient listening.
Thank you very much, Vidisha. Very nice. You really summarized very well the advantages and disadvantages of nailing procedures. Opinion from Sangeet on, and then Dr. Shinde. Can you unshare your screen, please?
Yeah.
Dr. Shinde, your opinion on nailing procedures for forearm?
Hello. Yes, sir.
Yeah. So your opinion on nailing procedures for forearm, what would you opine on this? Yeah.
As GSK sir has said, we do prefer nailing versus plating, and nailing is mostly suitable, even though the most solvers say that plating is better option. But I think we should go for nailing. In most of the patients, we prefer nailing.
Okay. And in case when you do a nailing and the radial bow is not well reconstructed, even then the patient regains complete supination, is what your experience is?
No, sir. No, in that case, then we have to opt for that case. But in most of the patients, we prefer for this both bone nailing.
Okay. Vidisha, if I would like to ask you one question. You said you take a lateral entry for ulna nail so that it can be buried under the muscle. Is that for that purpose, or is it because the bow you create and it doesn't back out?
I use a radius nail for ulna.
So
and
you are using, okay.
I bent it slightly
Okay.
so that it accommodates the canal.
Okay. Sangeet, you wanted to comment?
No, sir.
No. GSK sir, your opinion?
No, I don't think I should add anything. It's nicely discussed and nicely shown by Vidisha and Ajit.
Okay, thank you so much. Now with this, we'll move on to the next topic. And Sangeet, you can take up the topic on plating in complicated forearm fractures.
Yeah. So from nailing, we move to, am I visible and audible?
Yes, both.
Yeah.
Yes, sir. Yes.
So we move from nailing, simple nailing, complex nailing, complications related to nailing to plating, which also has equal share whenever you're seeing them, the patients at large. So the radius, it rotates around the ulna, and there are 5 joints involved in this movement. And hence, by some, it is called as an articular fracture, and that always requires surgery. Anatomical reconstruction in adults and adolescents is a key if you want a good functional range of movement and a normal functional hand. Displaced fracture, there are no controversies. Conservative treatment has a poor functional outcome, and hence surgery is indicated in all of these displaced fracture. And your surgery should be such that it should eliminate any external immobilization. Like nailing, we have also an equal share of complications related to plating. And how do you take care of them is all what we are going to see in this talk. Now, the plates, what we use for radius ulna, can also be used in different modes. like a compression plating or a neutralization or a bridging mode. And every case, you have to treat them individually after having analyzed these fractures configuration. So to start with simple fractures, which are transfers like this, they require a compression plate, and you achieve that a predictable union of almost 98% with a normal function is expected. The problem is when you have a oblique fractures, or you have a wedge fragment or a loose fragment which is unaddressed like this, where you have a good fixation on one side and other side, the other cortex is deficient. Here, trying to put an interfrag and capture that wedge fragment will add devascularization. It will denude the vascularity of that fragment, and that will lead for the fragment little to contribute in the healing of the fracture by a primary intention. And hence, instead of doing an interfrag, you should either use a bridge plate or use a graft on the opposite side to have a good successful union. When you have oblique fractures like this, instead of using an interfrag, the best is, like, even if the fracture is in the upper fourth, right up to the neck, you can use a plate with an appropriate approach, and you can achieve a union as good as a normal, wherein you restore the normal anatomy, you give a perfect functional range to the patient. In an elderly, when you have such combination, always a bridge plate is preferred, and you may afford to shorten them to improve the healing in those fractures. So the principle while treating forearm fractures is extra periosteal dissection, no devascularization of the exposure or the exposure of bone. Only what is underneath the plate should be exposed. Indirect reduction technique with a pointed towel clamps must be practiced. No circumferential clamps should be used, particularly for fixing the plate. Instead of that, you can do a delicate dissection, and the same can be achieved by pointed clamps, which do not devascularize the surrounding muscles. And that, if you follow, will achieve a predictable bone healing in an expected time. When we go to the extreme, we have one category of fractures, which are the Galeazzi, which have an associated inferior radial dislocation or subluxation. Here, the trick is when you are fixing, don't put all the screws. Fix the two screws in the adjacent to the fracture, achieve a temporary fixation, and then check for the inferior radioulnar joint, whether you have reduced it properly, and then fix the rest of the screws to achieve a good sound healing. Very often it happens that when you pronate, you can do a ballotment and check for the inferior radioulnar subluxation. Very often, even with the experienced surgeon, it is missed. And the reason is we address the middle third fractures or the proximal elbow injuries, and often it is neglected, and that results in an inferior radioulnar subluxation like this. In such situation, you require additional work to stabilize the distal radioulnar joint. Either if the ulnar styloid, if it is a large fragment, you can be fixed by various modes, or you can just put a pin from radius to ulna or from ulna to radius. A lot has been talked about the radial bow. Now, what is this radial bow? There are two curvatures, one proximally and one distally in the radius. And the proximal curvature angulates at an medially and anteriorly, and that angle is about 13 degrees. And the distal curvature is convex laterally, and it is about 9.3 degrees, and it is posterior, which is angling about 6.4 degrees. And whether you are doing nailing or plating, every attempt must be made to restore these two curvatures appropriately. Here you can see this is again a fracture dislocation distally, and this is how it has been fixed. But the problem here is you can see the curvature is exactly opposite of the distal radius, and the interosseous space has increased, but this requires a revision to restore and put the radius straight with the help of a plate, and then one can expect after restoring a normal bow, a normal realignment by a compression plate and a good function at the wrist and elbow. When we have such fractures which are extending in the distal metaphysis, intra-articular fracture, often we have a issue whether to fix the radius or the ulna. So the trick here is there are 2-3 things. One is how will you achieve the length, and how do you know whether your ulna is in an appropriate rotation. Fix the simple fracture first, achieve the length here. Both are communicated, the radius as well as the ulna. But I prefer to fix the ulna first. And how do I know whether the distal ulna is in rotation? If you see the proximal forearm, now the radial, the ulnar styloid process is at 180 degrees to the coronoid process. And similarly, when you have to see the radius rotation, the styloid process and the bicipital tuberosity should be opposite to each other. But this is not true. This relation is not true in every individual. It may vary. So the best way is to see an identical view on the opposite side while you are fixing these comminuted fractures. Also, when you have taken, now here you can see in the subsequent X-ray, the position of the ulnar styloid, and this is very abnormal. This usually happens when you have not taken a true AP and a lateral view. So a full supinated AP view, if you take, you'll have a picture which is on the left. But if you take in a mid rotation, you will see the ulnar styloid towards the radial, towards the radius. So don't get alarmed when you see it. Your view is not proper. If you restore the anatomy, if you restore the radial length, if you address the rotation in such comminuted fracture, this is the post-op, and you can see here how beautifully it has restored the distal radioulnar joint, and also the fracture has healed. 2 different principles have been used in fixing the radius and ulna. On the ulnar side, you can see we have used a bridge plating. We have ignored the comminuted area. And on the radius side, we have reduced it anatomically by interfrac screw and a neutralization plate. And you can see both have healed very well. That is the functional movement of the patient, full pronation and supination, and flexion and extension of the wrist. Plating the distal fourth of ulna. Usually earlier we had a thick profile plate, either a recon plate or a 1/3 tubular plate or a DCP. And to capture the small distal fragment of the ulna, we had to rotate and we had to struggle trying to fix a couple of screws in the distal fragment. So here is a case where you can see this is a non-union, segmental non-union of the ulna, where we could use only 1 or 2 screws in the distal large ulnar fragment. But we now have newer plates, locking plates, either segment specific or specific plate for the distal ulna, or hook plates, which can be used and have additional screws for the small distal ulnar fragment. From distal, we move to the Monteggia, where you can see there is along the ulnar fragment, there is a dissociation of the superior radioulnar joint. Maintaining the length is enough to reduce the radial head in its anatomical position. And you can see it went on to union and has a full functional movement. Fractures of the upper fourth of radius, which have comminution, which have osteoporosis, are very difficult, and malreducing them or not addressing them with the appropriate implant will lead to complication. And here you have to choose an appropriate approach. We have to reduce them, and we have choices of implant. Here, when you take an anterolateral approach, proximally it has to be between the brachialis and the brachioradialis, and distally between the brachioradialis and the pronator teres, wherein you identify the radial nerve, the arcade or the arcade of Stuthers, that is the superior border of the supinator muscles, and through which the posterior interosseous nerve goes in the posterior compartment. And then we have the superficial branch over the supinator, which supplies the superficial radial nerve, which supplies the radial 3 sense, that is a sensory branch, which supplies the radial 3 fingers. So we have to release the supinator, we have to derotate the head, and once you release the annular ligament, then you have the entire proximal radius in front of you, and you can mold the plate to the radial tuberosity, and then we can fix the plate as up to the radial neck, just below the articular surface, and have a fixation of at least 2 screws, and you can see that that can go on to healing well. In an elderly, when you have such bad injuries, here nailing probably would not be an appropriate solution. We have to plate, and you need a larger exposure where, as you have seen in the pictorial diagram, here is a radial nerve. After dissecting the supinator, this is the superficial radial nerve, which goes over the supinator, and that is the one which is retracted with a small periosteum elevator, and the radial nerve then continues in the posterior compartment as a posterior interosseous nerve. So having dissected that anatomically, you have the entire radius in front of you, and you can see here, after fixing the ulna, the radius is so comminuted, so realigning them and then just doing a bridge plate would be enough. So you can fix even such comminuted fractures, and that is the healing X-ray of that patient, where at around, I think, 6 months, the fracture has healed very well. The other way, what has been discussed is you can use the Metazo technique in adults, wherein you can do, after reducing it, you can use nails, so that if you don't want to dissect the posterior interosseous nerve, even that in certain situation where the radius is a longer segment and the tip of the nails, they are adequately placed in the subchondral bone, they will have a good purchase and hold the radial head till the union, and you can see that healing well. Segmental fractures like this, there are various ways by which they can, and the various techniques by which we can fix them. One such technique is fix the distal fragment with the 1 screw, and then you can use a distractor over a screw outside the plate proximally in the ulna, and then just use a distractor against the screw and the plate, so that the intermediate segments fall back in position, and then you can put 1 or 2 screws in that intermediate segment, and then complete the plating procedure like this, where that segment of the radius has been fixed by 1 screw after using the similar technique, and then distally 3 screws, and that has healed very well on the right side X-ray. Here you have a different situation where there is a segmental fracture of radius as well as ulna in a 30-year-old individual. The only problem here is the angulation of the ulna, which has not been addressed. The radius has healed very well, but the ulna remains to be little angulated. Here, probably the judgment of fixing the ulna was not appropriate at that time. Even though the fracture has healed well in expected time, he has a good flexion extension, but he has some loss of pronation on his left hand in such bad fractures. So to conclude, such fractures which are difficult can be addressed very well with the plating. Your complications can reduce if you restore them anatomically, and you can have a good function of the adjacent joint if you address each fracture depending on the configuration of the fracture and what it requires, whether it requires a bridge plate, compression plate, or spanning plate. You can also mix and match in the 2 bones your different techniques of plating to achieve a good result. Thank you very much.
Thank you, Sangeet. Nicely and masterly you have brought out fundamentals of plating, the principles, and use in real complex situations, giving excellent results for your patient. Thank you so much for that presentation. Any questions for Sangeet? Now we have a panel discussion on problems associated with the plating procedures on forearm bone fractures. And after forearm bone fracture, if I can ask you, Sangeet, one of the common problems I encounter is a closure which becomes very tight at the end of the procedure. Any precautions you take for them or timing of surgery? How do you manage them?
Off late, probably the cases which are presenting are coming quite early, and we are fixing them within 24 hours. And the only one which are neglected, which are coming late, maybe after 24 hours, they have the issue of the soft tissue swelling. In those cases, the priority is to fix the ulna first, and then we can keep the radius wound open in case you have that much of swelling, and do a secondary closure at a later date, because the radius will always be covered with the soft tissue, with the muscles. The ulna being subcutaneous should not be left alone or should not be left open.
Okay.
Even the VAC, we have tried to get early reduction in the edema and subsequently close them.
So some patients where you're not able to close primarily, you put them on a VAC, and maybe third day or fourth day, then you close the wound appropriately.
Exactly. By 48 hours,
Okay.
it dramatically reduces and you're able to get a secondary closure.
Okay, so that is your trick.
But always on the radial side.
Okay. Any opinion from GSK, sir, on plating forearm bone fractures?
Yeah, regarding the closure, as Sangeet has said, I agree with him. But sometimes, even cases, it is difficult to close. In those cases, there are you have to keep it open, and then sometimes you have to graft it. Skin grafting may be necessary sometimes. However, we are using the wires and K wires. We pass K wires. If there is a large wound, we pass K wires in, out, in, out, in, out on both sides. And we pass a wire between the exposed K wire on either side, and then go on twisting it so that the whole skin gets, even large wounds can be closed without skin grafting, without grafting. And that has given good results in many cases. So these are the two methods of the either you can use, if there is a very large wound, this is not possible, you can use a skin graft, or if there is a good, reasonably medium-sized wound, you can use this method of K-wire and closure by slow closure every day. This method.
Any problems, Sangeet, encountered after a plate removal and you had a stress fracture? How do you manage them, or are there any experiences on that?
I don't remove, with the experience which I had, where since I had vaguely, it so happens that at the time of fixation, we vaguely tell them that after 2 years, the often question is asked, when do you remove the plate? So we tell them at the end of 2 years, you can come for plate removal if it is symptomatic. And to them, some of the patients, they insist on removing the plate. So ideally, the forearm plate should not be removed at all. And either at the screw hole site or even at the old healed fracture site, because we get a primary union. And they, after a trivial fall, they are known to have fractures at these two levels, or those who are plated, if they have a violent fall, they have at the end of the plate. So these are 3 injuries which are very common related to the implant after the healing. And but routinely now I don't recommend them to remove the plate. They can be left alone unless they are symptomatic.
Okay.
Okay.
Phadke sir, your
advantage This is an advantage over plating nail over plating, because you can remove the nail after the fracture has united, and refracture is almost not advised. But yeah, as I agree with you, that we should convince the patient that a plate should not be removed, and there is no harm even if it remains your lifelong. There is no harm. They are afraid that sometimes may something cancer may occur, or somebody has told them something. So all those are all not they are myths, and convince the patient that no need to remove the plate. They are usually convinced often them.
So as per AO principle, though they recommend plating, so functional outcome is same, I think, with nailing and plating.
So your question is, how is the functional outcome after a
Yes,
nail
sir.
and a plate?
Functional outcome with nailing versus plating, functional outcome.
Sangeet, you would like to answer that? The functional outcome after nail? Vidisha, you would like to answer that question? The functional outcome after a nailing procedure or plate for both bone forearm?
There are few papers on comparison of results of plating versus nailing, and most of the papers have said that functional outcome is same. Only thing, few papers quoted that the non-union rate with nailing is more, slightly more than the plating group.
Okay. So I think that must be with the open nailing procedures, not with the closed nail.
I think so.
It was a previous era reporting where it was a open nail. Most of the times healing with a closed nail is almost assured.
Yeah.
So the results with the closed nailing are superb. Phadke sir, your opinion on plating? You must have done so many plating procedures yourself, though you advocate nailing in majority of cases, but you must be choosing some patient. So, so is it what Sangeet says, you from a city dweller, you would choose a plate procedure?
Not really. Actually, it is indicated by the fracture and not by the patient. The patients will follow whatever you say. I am somewhat of a dictator. I tell them it will take 1.5 months in a plaster, and they accept it. There is very rarely somebody who will say that I don't want a plaster, or I must go back to work in 1.5 months. My experience is a little bit different. Businessmen are the ones who are very keen on returning back to work. Those who are on salaried jobs prefer to take holidays for 1.5 or 2 months, and after a fracture. And even if they want, they can go back to work, they will not go back to work. Fortunately for the forearm, even with a plaster, they can do most of their work, except maybe skilled work, and it's not a lower limb injury, so they can go back to work if they really want to. Like businessmen, especially shopkeepers, they will be back to their work immediately after discharge, even with a plaster cast, and they will continue with the work. I do plating mostly for Galeazzi and Monteggia fractures, and occasionally I will do plating for some patients who like say whose relatives are doctors and they don't want nailing. They say no, my relative, my brother-in-law said that you must plate this fractures, and then I'll do plating. Otherwise, my preference is for nailing, and I am very much happy with the results of nailing. I have never regretted nailing any patient. In fact, the poor results of plating are so bad that I am really scared of handling patients who have been plated by by doctors who are not skilled at plating. And then they get a big segment of avascular bone or big segmental bone loss, and if it's infected, God help them. Whereas with nailing, this problem almost never occurs. Infection doesn't occur. So my preference is obviously for nailing, and I've been doing it for so many years now. But open nailing, I won't advise. If you have to open the fracture, then it is better to plate the fracture. And if you can get it closed, then nailing is nothing like nail.
Okay. And your philosophy of plating one bone and nailing other bone, or do you strongly condemn that configuration?
No, I don't condemn anything. There are no rules in orthopedics. So yeah, whatever works for the patient is good. But
Okay.
primarily, I won't do this.
Okay.
Primarily, I would either nail both the bones or I'd plate both the bones. But secondarily, that is, if I have nailed both the radius and ulna, and often ulna goes into non-linear, and then I have to revise it, then I prefer to plate the ulna. You're leaving the radius nail inside. There I'm not worried. Why I am not against, or why I'm against primarily using different techniques for the different bones is that the plate works by rigidly holding the bones together, whereas the nails will allow some collapse, it will allow some micro motion, and you're confusing principles by nailing one bone and plating the other bone. But whereas in the non-union, one bone has already healed. So the other bone which has gone into non-union can be treated as an individual bone, and you don't have to worry about what has been done to the other bone.
Okay. Thank you very much for very useful tips. Dr. Shinde, you had any cases where you nailed the patient and you mobilized immediately without putting a plaster, or you always give plaster?
No, sir, I always give plaster.
You always
Because
give
in area I practice, I don't rely on patient, because they will, if you don't apply plaster, they will do whatever, any kind of, always apply plaster.
Okay. Vidisha, your opinion on how do you choose your patient for either nail procedure or a plate procedure? Are there any criteria in your
Mid-shaft fractures, I go for nailing if they are closed and done closely. If any fracture requires open reduction, then I will go for plating.
Okay.
But I found that nailing patients are more happy because there is no scar. And in almost 50% to 60% never come for follow-up after 2 months.
Okay.
Some patients may come after 1 year or 2 years for nail removal. But most of they are happy, and they so they don't come back.
Okay.
And for narrow medullary canal, I go for plating.
Very narrow canals you
Yeah,
have
and
to
distal and proximal fractures.
Okay. Okay. Thank you very much for those useful instincts and useful tips on nailing and plating. Now we move on to the next lecture.
I
Yeah,
have one
GSK sir.
comment.
Yeah. Please, sir.
When nowadays, of course, Vidisha has taken over everything, forearm and upper limb. When I was doing in the initial phases with Talwalkar's big nail, and I used to test them on the table after passing as big a nail in the areas as possible. And on the table, I used to see whether there is any rotational mobility. If there is no rotational mobility, I would not have asked the patient to not to do any heavy work, but no plastering was done in those cases. Only in those cases in which there is even a slight movement, rotational movement, I used to plate them. Secondly, I don't agree with Ajit saying that there is micromotion and all that. But if you put a good plating, the patient can really go back on next day for working, and a compression is necessary in all cases. When there is a single bone, if there is comminution, of course you can do bridge plating, and even then in the bridge plating also there is no need for plastering. So that's a big advantage really, that no plaster is there. So that is my comment.
Okay. Sangeet, yes.
So if since I am not doing enough nailing, so I cannot comment on that, but which are the non-unions or complications related to nailing which are coming to us for plating? These are the one in which very thin nails have been used.
Yeah.
Yes.
Or where they have bent at the diaphysis, or you have used nail in a very wide medullary canal. A single nail has been used in a very wide medullary canal in an elderly, or there is an extensive comminution, or you use nailing in extreme, either distal fourth of radius or upper fourth of radius, where the rotational stability is not good enough with the nail. So those are the ones probably are not suitable for nail and combination of a plate and nail. So there are a lot of non-unions related to that are coming. So in my opinion, these are the one not based on the experience of nailing, but based on the complications related to nailing, which are coming for treatment of a non-union.
Okay. So
And
yeah, so those
Chandak sir, what is your Chandak sir? I
Yeah.
want to know your expert opinion regarding this nailing versus plating. What do you prefer?
So I have interesting collection of around 14 patients where one side is nailed, the other side is plated for both bone forearm. And in that series, all the patients say our nail function is better. Cosmetically is one is fine, but functionally also they feel that even they are able to hammer with the nail hand. So functionally also they are better, no pain. Very rarely they would have inflammatory pain on a nail side, whereas some amount of inflammatory pain at times with the plating side. So the patients were quite, I am very comfortable with the closed nail procedure. As Sangeet said, not with these problems, where a very slender nail, very small medullary cavity at the extreme ends. So where nailing is not a good indication, but of course, for all Galeazzi and for Monteggia fractures, I would always plate those patients. So I think we have to choose our patient, what is to be given. And say some patients are there, if somebody falls in a Middle East and he's coming to India for a treatment and he goes back to that country, I think the most compatible in their mind and in the follow-up surgeon's mind would be a plating procedure. I think there we have to choose appropriately. Yes, Sangeet.
And sir, you had asked a question, what is the literature regarding a comparison of plating and nailing? Now, whatever is the literature related to nailing is an older literature where they have used a single nail.
Yes.
In a medullary canal, which is wide, that has not given enough stability. Probably only here in India, we are adding a stacking of a nail to improve the stability. So that comparison is not available. Hence, the earlier literature reports a complication which is very high related to forearm nailing. And hence the switchover was towards the plating. And it is not that here the category of patients are different. So even those who are on daily wages, those who are hand to mouth, their expectation is like, if you put them in a plaster, how will they go for work?
Yes.
It is not the richer class. It is not the office class. Even the poorest daily wage earners, to them, putting a plaster for 6 weeks is an issue because they are hand to mouth.
Yes.
So convincing them to be in a plaster is little difficult for us.
So Sangeet, do you think that after plating, the laborer can do labor?
No, sir. At least they will not use the arm, but that hand will be free for even toilet care, bath. They don't have relatives to take care. They are living single.
Yeah, but they can't go for a labor.
I'm not talking about the heavy work, a labor work or a farmer going to his job, but at least day to day brushing, eating. You need somebody to feed them in a plaster. They cannot eat, sir.
Yeah.
Bath,
The conclusion is that you must use as large a nail as possible. If the largest nail still has a roomy space in the medullary canal, you should add another nail and make it more stable. So that would be equivalent to plating.
Right. So that was really wonderful discussion on the advantages and disadvantages. And with this, we'll move on to the next lecture by GSK sir. GSK sir, can you please share your screen? You'll be talking on management of gap non-union and
Hello. Can you see my slide? And
yes, sir.
Okay. Now, gap non-union of fractures of radius and ulna. Okay. Now, the diamond concept of Gawhale was published in 2007, which was for fresh fractures. But
Slides are not seen, sir. The screen is seen, but the slides are not seen.
can you see now?
No, sir, still not seen.
Sir, it is not moving.
I think you will have to share again, and
Yeah.
again we are able to see screen sharing. Icon is there, but we are not seeing the slides per se. We are seeing the screen being shared, Sunil, but not able to see the slides.
Can you see?
No, still we are just seeing you have started sharing screen is the icon we are seeing.
Sir, can you move ahead? Next slide.
Screen चालू आहे.
Can you move, Sunil? Move to the next slide.
Yeah, I'm moving to the next slide.
It is not moving this side.
How can it? It is already there.
No, not there, not there.
Complete close number.
परत screen share करा परत. This share कर. Share ला दाखव.
Yeah, now I think we are able to see that. Yes.
Okay, thank you.
Yes, thank you, sir.
And a diamond concept of Gawhale was published in 2007. In 2016, Ms. Kalso presented that this can be used for non-union also. So in the forearm non-union, what is required is remove all the dead tissue so that you can get the osteogenic cells population more. The secondly, mechanical is that compression by plating is more preferable to non-union, and which is not nailing is not possible in non-union. Thirdly, fill the gap by bone graft or substitute, which gives you an osteoconductive scaffold. And then in for growth factors, BMP2, cancerous bone graft is ideal. We are using injection teriparatide for all non-unions. This has given us excellent results. It's not moving now. Yeah. Infected non-union, I will just quickly go through the basics of thing, just to revise your basic concepts. Principles of treatment, 4 pillars of success are thorough debridement, like just giant cell tumor that you do resection, similar debridement should be done. This is most important. You have to convert the infected non-union into a aseptic non-union. Stable fixation from day 1 to the last day of healing is another very, very important point. And therefore, what is needed is compression by the in the forearm. Compression is needed. If there is a stable fixation, even an infected non-union can unite. Culture specific antibiotic for 6 to 12 weeks is necessary. This is how I'm talking about infected non-union. First week intravenous, at least intravenous injection in the first week, then you can use it orally. Monitor renal function is another very, very important point. When you are giving a high dose of systemic antibiotic for a long time, local antibiotic reduces this period. And now, as I told you, healing aids are bone graft, growth factors, injection teriparatide. So these are the 4 pillars to get success. Thorough debridement, as I told you, most important in a gap non-union is important. Debridement extremely important, decides the outcome. Reset dead bony ends till you get the paprika sign positive. Shingling, intramedullary reaming, local antibiotic, rods and beads. Importance of local antibiotic is local concentration of the serum is local concentration in the fluid at the local site is 200 times more than the serum concentration. So this kills the bacteria even if they are protected in biofilm. The resistant bacteria, whatever may be the resistance, they are resistant bacteria are also killed by such a high level of concentration. Any type of organisms, cocci, bacteria, whatever type the organism, they are killed by this high level of concentration. Therefore, that is the reason why we can use, we may not use also systemic antibiotic, or even if you want to use it for a shorter period. Avoids complication of prolonged systemic antibiotic, gives stability if you are using musculate type of fixation, fills the dead space, that is I am talking of local antibiotic. Cement forms musculus membrane, calcium sulfate gets absorbed completely and acts as a dead spacer. Another we have forgotten about this is the Ciarni mother classification. I think we need this classification to apply our for infected non-union. We should apply this classification. The anatomical classification and physiological classification here divided into two. In the stage 1, it is a medullary infection, which usually occurs after nailing, and the treatment is reaming is very important, then debride, antibiotic rod and beads, and then replace it with normal interlocking intramedullary nail later on. Stage 2 is superficial, just superficial to the cortex, superficial cortex is involved. So just treatment is superficial debridement and put antibiotic beads, and that will heal up. Now, stage 3 is localized infection. The treatment is a local excision and antibiotic beads, and this is how it can be treated. This is the excision that should do. In the 4th stage, this is a diffuse type of infection. It is a segmental diffuse infection. So you have to, treatment is segmental resection, segmental excision, and then reconstruction. So the physiological classification is normal host with good immunity, compromised host with poor immunity, and treatment worse than disease. That is, these are the moribund patients in which you should not do any surgery. Now, infected gap non-union forearm is reconstruct after the infection is controlled by fibular graft, autograft, allograft, or vascularized graft, then fix it by plate or nail, or nail plus external fixator. This is number 1. You can do bone transport, but usually not done because there are 3 nerves and 2 blood vessels. Only it is possible to do bone transport in ulna without complication using unilateral external fixator, like B.B. Joshi's apparatus. Musculus technique may be done. Now, another very important option is available is one bone forearm. This is only available in forearm. Nowhere else it is available. So in some indicated cases, this is also can be done if there is a large and so on. I will tell you, I will show you some cases. This is a Dr. GP from Nepal, 35 years old. He had pain, swollen, but no sinus. The implant was loose. The laboratory test, WBC, ESR, CRP shows that there is infection. On opening, we found metal reaction and lot of pus inside. So this was debrided. The yellow dead bone was removed, and till you get the paprika sign as you see in this slide. And then the beads were kept inside. And when the infection was under total control, we did plating. and bone grafting by fibular graft. Muscular technique with fibular and with fibular graft can be done, but without muscular technique, the results are equally good. So in this case, we used fibular graft, as you see here, and put a nail. Then why not put a plate? Yes, plate can be put, but a long plate is necessary. And if you are a little doubt, but you do not put plate, you can do a nail and plus an external fixator. Only nail is very unstable. So you have to do Ilizaro. Ilizaro is very simple. One ring distally, one ring proximally. It's very simple and it compresses the fragments and additional stability it gives. And this is needed when there is you are not using only as unlock nailing. If you are locking nail, then there is no need for external fixator. This is also true for femur, tibia, everywhere. When you are using antibiotic nail, we should add an external fixator, maybe Ilizaro or maybe a unilateral external fixator. So this is how the fracture united nicely, and he had good movement except some restriction of supination and pronation. This is another 12-year-old girl had infected non-union, was treated with plating, fibular graft and plating. Here we have used 2 plates for compression. May not be necessary, we can use 1 plate also. There is a problem here is the stress riser. But in the upper limb, we have found, we have used many times the 2 plates, but stress fracture has not occurred because it is not a weight-bearing bone. But still, however, it is preferred to use a long plate, and you can compress with using a long plate at both ends of a segmental fracture. This is a 52-year-old lady from Kenya. She has an open fracture, and surprisingly, they had tied the ends by some colored threads which were found, and there was a severe infection. This was again treated with debridement, thorough excision till you get the paprika sign positive. Beads were put, and again the same treatment was given, fibular graft with nailing and Ilizaro. She did well. Now this is a case, a boy, gap non-union, radius was shortened due to gap, and this was treated with tricortical graft and cancellous bone and fixation with plate. And this is how you can see the graft, remnant of a graft, you can see, and the fracture united nicely. But he had stiff hand fixed in supination. So this was treated with Sowe-Kappenji procedure, and she had a good function. Problems of forearm non-union are supination, pronation problems, functioning of the distal radioulnar joint, equalizing the radius and ulna, maintain the intraosseous membrane. Now, DR is a dislocation. Ulna, if it is longer, do shortening and fix by plate. If there is a chronic dislocation, irreducible, one can do Darach's procedure, a modified Darach procedure, or Sowe-Kappenji. If the DRUJ can be reducible, then one can do a reconstruction of by using a tendon graft or something. Acute dislocation in the acute situation, fracture after fracture, reduce, and you can put 2 KYs, as I told you, proximal to the joint, radioulnar joint. This is modified Darach's. and some people use extensor carpi ulnaris as a spacer. And if there is impingement, sometimes you get impingement by styloid process, and in that case, you have to excise the styloid process and reconstruct it. If the DRUJ is unreducible, so Shinde is the answer. And if it is reducible, you can reconstruct with the tendon as is shown in this figure. Now, there are the comparative studies has been done by Svenna Hand Surgery, journal in Hand Surgery published. This compared with the Darak procedure with the Shinde. There is no difference between the two functionally. However, Darak has instability, more instability. And that is the complaint that patients give. And in Shinde, there is a heterotrophic ossification sometimes occur. So this is a case of non-union Galeazzi fracture dislocation. This is, you can see the dislocation. This was treated again by Shinde and fixation non-union with plate. This is another 9-year-old girl, 10-year-old non-union with gap. This was treated with plating and bone grafting. But she developed synostosis. Excision would give excellent results. We have done in other cases, has given good results, but this patient had no pronation, but refused further surgery and disappeared. Now, Musculus technique can be used in this patient. We have used in this case Musculus technique. Somehow here the preoperative X-ray is missing. We could not get the preoperative X-ray. This was treated by Musculus technique, and after the 6 weeks, we did fibular graft, and this had good results and good function. This patient had good function. Tips for Musculus technique are: spacer should cover the ends of the fragments. This is often I see that the ends are not covered, and the size of the musculus is less than the diameter of the shaft. That is not correct. The spacer should be 1 or 2 millimeters larger than the shaft, as you see in that case that I have shown you. Removal of spacer is another important point. When to remove the spacer? Ideally, at 4 to 6 weeks, the membrane is very, very active. Large number of growth factors are produced. It acts as a periosteum more often, and but the membrane is very thin. So while removing, you are more likely to damage the membrane because it is thin. Therefore, the optimum time is 6 to 10 weeks. During 6 to 10 weeks, before 10 weeks, you must remove the spacer and put the graft, whatever you want to. After 3 months, the whole membrane is converted into a fibrous tissue and therefore loses its function of a membrane, what is intended for. If you want to use a cancellous graft and substitute, the percentage should be cancellous graft should be 70% and substitutes must be about 30%. If you use a nail or a nail, then that also gives you some percentage of less percentage of using cancellous bone, and that works very well also. Now, antibiotic also again is a controversial topic. We use vancomycin and tobramycin for in all cases when we use Musculus technique, and Musculus himself is against it. However, the whole world is using antibiotic in in the cement. Now, I myself, Dr. Tanna and Babulkar met him at the American Academy, and I asked many questions. And one of the important question was the failure of Musculus technique occurs due to infection. And this occurs, the world literature shows, between 20 to 23% of the cases, the failure occurs, and the failure is due to infection. What to do if infection occurs? That was the question I put him. He said, repeat the technique. That's the only way. In this case, note how nicely the membrane is formed. You can see here the membrane formation, very nice membrane formed. As soon as I cut and removed the plate and put my finger, the gush of pus came out. So this is the one big problem of Musculus technique. So the answer is very, very thorough debridement and antibiotic. Musculus technique in forearm, fibular graft is ideal. Autograft or vascularized graft results are when you are using autograft or vascularized graft, results are equal. So we prefer autograft because the results are doing a vascularized, very technically very difficult, needs a specialized center for that. But the results of using just a simple autograft without vascularization is equally good. So cancellous graft may not be used in forearm, not necessary if you use a fibular graft, autograft. Musculates, as I told you, is not much of benefit in forearm. Now, beads elude more antibiotic than a single spacer that you use in muscular technique. So beads, you put beads because it is the surface which is the more important than the single rod. There is a recent paper, this month's paper in JOT, that beads are now converted into discs. Each disc is connected with a thread. And because the discs have got more surface, the illusion is very, very high. So they have compared beads, making beads, round beads, and discs. The discs elude more antibiotic. Only advantage of using a single rod as a spacer is that it is more stable than the beads. This is an interesting case. This boy had pathological fracture, probably fall and then infection or chronic osteomyelitis. So he has, we had to remove that diaphyseal sequestrum, total diaphyseal sequestrum, and this was created. This is in August 2017, and we put antibiotic rods, antibiotic beads, and infection was under control. And our plan was to put a fibular graft and reduce the radius ulna and all those things, and reconstruct the whole procedure. But unfortunately, the patient disappeared and appeared after 4 years in 2021, like this. In this, you can see that there is a radius has dislocated and enlarged. Head is enlarged. There is a dislocation. You can see here. The ulna was good. There was some movement here in the ulna, and so you can see that there is this is a chronically dislocated radius ulnar joint, on both sides, proximally and distally, enlarged radial head, dislocated ulnar head also, large gap, you can see this, and radiocapitular joint can't be reconstructed because of the chronicity and large head. So the one bone forearm is the only answer for this case. So we did radioulnar head, proximal ulna was reduced to distal cut osteotomy of the distal radius, and the proximal ulna was connected to the distal radius. So he did well. After 9 months, he came and he has the fracture they have united, the ulna has united with radius. But he developed a heterotrophic ossification and a funny looking coronoid process, the tip like that. But in spite of that, surprisingly, he had very good function, fairly good function. This was unexpected. Extension of the elbow, also pronation, supination. They have somehow the children can do this supination, pronation. But this we have not, we have done in adults also, one single bone here in some cases when it was indicated. In those cases, the adults do not do this type of pronation. But in children, they somehow do pronation at humeroulnar joint, as well as, of course, the shoulder also contributes greatly to the pronation. And good hand function, supination, pronation, you can see here. And this is how the function is there of that. So take home message is gap treatment, infected gap treatment in forearm is a thorough debridement. Fibular autograft we strongly recommend. Bone transport we don't recommend because of the complications that you get of the nerves and blood vessels. Musculus technique may be done, but the results are equal to using autograft. One bone forearm can be done in some indicated cases. Thank you very much.
Thank you so much, sir. That was a wonderful presentation, a lifetime collection of cases and wonderfully done cases with a lot of take-home message. Any questions to sir? So, if I can ask, what is the most common antibiotic you are using in antibiotic spacer? Is it Vanco only?
Vancomycin and tobramycin. Because now there are only 5 or 6 antibiotics are available for that. Because they should be thermostable, they should be broad spectrum, and available in powder form. So all these, very limited number of, say about 5 or 6 antibiotics are available. Of these, vancomycin, combination of vancomycin and tobramycin is important. What is important is I have seen the people are using only 2 grams of vancomycin and 1 gram of tobramycin for a 40 gram of cement. This is not correct. You need at least 4 gram and 2 gram. But if you use more than that, some people have used more than that, 6 gram and 4 gram, but then the cement becomes brittle. Therefore, the optimum concentration is 4 grams of vancomycin and 2 grams of tobramycin in 40 grams of cement.
And the requirement of spacer in forearm is very small.
So you can use 20 grams of cement, 20 grams of cement and half of them, 2 grams and 1 gram.
Okay. And tobramycin is routinely available as a liquid form. So you have procured tobramycin as powder form?
Yeah, it is available, no?
Okay.
Yeah.
You have as powder form. Okay. Sangeet, your opinion on managing, I think sir has a very large experience on managing.
But I was just seeing the number of cases. Does it require such aggressive treatment like weight-bearing tibia or the femur?
What do you mean by aggressive? This is not very aggressive.
Excision, that large excision.
You want to leave it like that?
No.
Sangeet, the amount of excision of dead bone is what you are asking?
Yeah.
Okay.
You don't want to, paprika sign, you want to use a small bone and keep the dead bone at both ends?
No, not the dead bone, sir. Excising that large a segment. Does it really required in radius and ulna?
So that means, if you use a smaller one, you have to go on cutting till you get a bleeding surface. So now, if you don't do this, then there is a
What I was trying to say is in earlier times, where we never used to see X-rays in which, am I audible?
Yeah, you're audible.
So earlier times, we never used to see where so much excision of the radius ulna was done. Today, we have become very aggressive. So earlier, have we seen non-union where we have not resected that much bone? Still they united.
But they must have been left with a sinus or something.
These cases are chronic infected non-unions and some 3 to 4 debridements in few patients.
Okay.
And we went on resecting till the infection subsided. Few cases were repeatedly debrided. That's why the gap is big.
Okay.
But
so one more thing I was talking about is that instead of every centimeter cutting the bone, you put a drill bit at every centimeter, and where you get the bleeding surface, there you cut. That is the concept. So I have not understood, Sangeet. Do you want to do a small resection and keep the avascular bone at the bony ends, and that avascular probably get vascularized? That is what you are.
No, Vidisha explained that your cases where the one who had chronic osteomyelitis for a longer time, in which you had done repeated debridements earlier. So this was not on day one.
Huh.
Am I correct me if I'm wrong?
This
That
was
is what
not
I've
on day
understood.
one. Not on day one.
yes.
But hello, sorry to interrupt, but Dr. Sangeet, if even day one case has come to you with the infected non-union, and if you get the bone you need to resect on the table, if you're not having the punctate bleeding at
Aware of it, I'm aware of the treatment. I'm aware of the treatment, what has to be done. So the issue here is the radius and ulna is covered by a good muscle envelope. It has a good vascularity, unlike the tibia. So do we have to do that aggressive debridement?
What do you do?
Because we are not seeing such bad infections in forearm. Post-operative infections.
Yeah, we are getting daily cases of infected non-unions and chronic osteomyelitis. And some are having drug resistance. They are not sensitive to sometimes vancomycin. Then we shift to Supasep, sometimes gentamicin, tobramycin combination like. And many of the patients need repeated debridements for getting their infection cured.
Or sir, to put it in a appropriate words, is circumferential excision of radius and ulna. Is it required really? Can we not get away by removing only the dead part? So that will end up in like retaining half of the circumference of one of the ends, rather than leaving it as a gap. That was my question.
No, you can't get half living in, half dead, half circumference. The whole, either it is completely dead, or it is the whole circumference is dead, or it is partly. I don't think there is partly the half the circumference is living and half is dead. So you have to remove completely, so that you can put a graft also. If they are, suppose you have circumference in, I am talking in forearm. If you cut it, circumference is straight cut, and if you cut the fibula straight, so that you can put it nicely and compress it.
So the intercalary graft always incorporates. Do you face any problem with either ends?
No, really, we didn't face any problem. One tip I tell you is your graft should be about 2 to 3 millimeters, 4 millimeters more, or 5 millimeters more than the gap, and then you pull them back together and then put it. so that it gets compressed, and then you again compress with a plate. So, of course, one or two complications have occurred again, infection and the graft has failed and things have happened, one or two cases, rarely, not that 100% success in all cases. But then we have to repeatedly done it, and second time, ultimately, we get success with some complications like pronation, supination and all.
So we have in these gap non-unions, either a Papinov or a cancellous chips for filling the defect, or a tricortical iliac crest graft, or a fibula. So out of that, which is the best, sir?
The fibula, I think, is very suitable for radius and
in the
ulna.
presence of infection, earlier infection.
No. In infection, you have to control infection. Unless your infection is under control, the graft may not take. So,
no, sir, once everything is clear, we have a gap non-union, and we have a choices of these three grafts. So what is your choice is my question.
My choice is,
infection is all cleared.
Your first important point is that there should be no infection. You have to convert the infected non-union into an aseptic non-union. And then the fibular autograft is the ideal treatment. You can, of course, vascularized graft is also very good because it takes rain, and Ganga Hospital has shown recently very large number of cases with a vascularized graft because they have a vascularized group, and they have also used allograft also. But allograft availability and the all problems. But autograft, I think, is the ideal for us thing. And I told you, even musculus is not necessary because it's equally good results with autograft. But musculus has one advantage, is that it becomes more stable. If you put just K wire in that, and it becomes more stable. And you can remove it and put up fibular graft. So my fibular autograft is very ideal for radius ulna, provided your infection is under control.
So very often it happens that we see a gap non-union in only one bone. Other has already united.
Yeah, only we have to do that one only.
One bone.
Bone.
And while
when there is a problem of one bone, you have to be very careful about the distal and proximal radioulnar joints. And you have to put probably in the distal, reduce it properly, put a K wire proximal to distal, 1 K wire to keep it like that, and then put graft one. I have shown you one case in which there was only one bone, and one bone other was pelted and united. The other one infected, ulna was infected, and we used a graft there and plate.
Sir, my question is, during the intermediate treatment of infection and till for the final treatment, that period where you have done repeated infection, use a Masculine technique or something else, when one bone is intact, do you need a stabilization of the other bone while treating it?
We have to, I think. We have to, otherwise there will be, suppose the radius, of course, is the one. Ulna you can tolerate to some extent. Ulnar non-union also functionally okay. I do not know about if there is a big gap of ulna, how the radius would act only alone. I have no experience about that. But I feel that if there is a large gap in the ulna, it will be very unstable, and the fragments will be moving like that. Even, when you do Soe-Kappanji, the problem is there is a gap there, and the problem is instability. So suppose if the radius is united, and if there is a gap in the ulna, probably we have all done reconstruction. We have no experience of leaving the ulna like that. But I feel that it should not be left because this is very unstable. The proximal and distal fragments are very unstable, as in Soe-Kappanji. And the patient will have some complaints about it.
Also, Sangeet, it becomes nice to plate it later on because you have created a musculus membrane and you have kept a cement spacer. So space is available for next reconstruction also. Otherwise, all the fibrous tissue would keep him. So the next dissection also becomes easier if you keep a stability and spacer. Phadke sir, your opinion on defect, non-union and reconstruction? You have used fibula most of the time? You are muted, sir. Phadke sir, you are muted.
I agree with Dr. G.S. Kulkarni, sir. Because the fibular graft is the one that I prefer unless there is a very small gap, in which case I use a tricortical iliac crest graft because that vascularizes faster. But otherwise, fibular graft and plate, but I don't use Ilizaro.
I think that was Sangeet's question also. In between iliac crest graft, say for a small 2 centimeter, 3 or 4 centimeter, you would prefer a iliac crest graft rather than a fibular graft.
And a plate.
And a plate. Okay.
And a plate. So that in my limited experience, I don't have so many cases because for the past 8 or 10 years, I have started referring all my infected cases to institutions. I don't treat them unless they are infected in my hands, which is very rare. So I just refer them because I am tired of treating infected cases. It becomes a big headache. And otherwise, in my opinion, the tricortical graft from the iliac crest incorporates very fast. And there's no risk of non-union at one end or breakage of the graft later on. And these plates are never removed. So I really don't know whether it has healed or not, but it seems to work. But if the defect is like 3 centimeters or 4 centimeters, then obviously fibula is better.
Yes, I agree with Ajit. And I showed you one case in which we have used the iliac crest graft and cancellous bone surrounding it. That was when there is a small 2 centimeter or 2.5 centimeters gap is there, we can use the iliac crest graft.
Okay. With that exciting presentation and discussion, I think Sangeet, can you present your case now?
It is similar to what we have discussed.
Yeah.
And now this is a 26 years old boy. Am I audible?
Yes, yes.
Yes, yes.
Yeah. A combination of nail and plate was done elsewhere. And he presented in, I think, 4 years back with pain and restriction of dorsiflexion. So that is the tip of the radius nail, which is not allowing him dorsiflexion and to carry on with his day-to-day activities. There is probably a non-union here at the radius, and the ulna has already healed. And there is a shortening of the radius as seen here. So he was advised a treatment for the radius, but he disappeared and he came after a year where that non-union has now completely healed. His botheration was only the impingement and restricted dorsiflexion. And the nail was removed. Now, so he has a variance, radioulnar variance due to radial shortening. Now he became greedy and he wanted more, something more, where can you restore or give me a better function is what he was demanding. So what can be done? His movements were not improving as expected. So what can we do for him? I think this was his right hand.
Okay. Any solutions, Phadke sir?
Yeah, I would remove the ulna plate. I would resect the neck of the ulna, bring the ulna down, and put a screw through the ulna into the radius. That is the Kapanje procedure, and that will improve his supination and pronation. Whereas the dorsiflexion, if it's still restricted, I doubt whether it is ever going to improve. So you must have
So you would not consider lengthening radius or shortening ulna?
shortening ulna. The Kapanje procedure is a shortening of the ulna.
Okay. GSK sir, your choice in this?
Yeah, now, Sangeet, I want to know how much is the movement there at the radial ulnar joint?
This is about 3 years old, and he had about from mid-prone, about 90 degrees of pronation and supination. Not a complete forearm pronation and supination.
No, I am asking about ballotment of the ballotment test.
There is some ballotment, but not classical.
Not classical. Okay. Then I would remove this and shorten the ulna, and so that you can restore the radial ulnar joint and see whether it works very well.
So you mean you will do the osteotomy at the old fracture site?
Remove the small amount of calculated amount of ulna and join them together.
So you mean to say you retain the same plate, you remove the 3 screws,
remove the
osteotomy,
remove the plate.
Okay.
Vidisha,
do osteotomy. Can we retain the same plate and do the shortening as GSK sir has said? Like you remove only the 3 screws from one end, shorten, and then again put the remaining 3 screws.
Yeah, if the bone density is good, then the same plate can be used after shortening to match the radial ulnar variance. You can use a compression device for that.
You can, why not remove the plate? Just remove the plate, do calculated osteotomy, remove the piece, and then do another reapply another plate.
That can be done. Locking plate can be used, but if the bone density is good, same implant can also be used.
He's just 26 years old. The quality of bone is here very good.
Yeah.
I think same implant can also be used.
Sangeet, if you want to retain the plate, remove the screw on one side.
Yeah.
How do you execute the osteotomy very nicely? So you will have to bend around and move around onto the other side. So why not remove the plate, resect the calculated amount, maybe appropriately around 1 centimeter of ulna?
So the safer option, all of us think, would be shortening the ulna.
Not radius lengthening in your.
No, I'm asking.
No.
Shortening is more easier than lengthening after 3 years.
And oblique osteotomy, a step cut osteotomy, or a classical transverse osteotomy.
Yeah.
So what is best, sir?
A step cut is better because healing is, that is runout suppression.
The surface area is more.
Okay.
Or you can control the rotation better with that.
Yeah, that's right.
Sorry to interrupt, sir. Again, if you shorten the ulna and if you fix the plate, the purpose is not going to get solved, because at least either you have to do a Savai Kapanji for that. Otherwise, pronation, supination, how you are going to improve it just by shortening the ulna and putting the plate?
So that is what I asked him, that whether ballotment has got some movement. If there is some movement, then you can do a reconstruction of the, you can join, because that will give you a better function than Savai Kapanji or Darax.
No, after shortening, if the distal radioulnar joint variance is neutralized, and if the ligaments are intact, then there is no need to use a palmaris tendon graft reconstruction of DRUJ ligament, if after shortening the DRUJ is stable.
So Sangeet, whenever such a clinical condition is there, there are n number of
options.
Varied option, and we are always worried whether the result would be optimum or not. So that's a real.
Even we can do a distractor, do osteotomy and distract gradually. Vidisha.
Yeah, this radius lengthening can be done. Gradual radius lengthening with a fixator or circular fixator. Acute lengthening will be problematic, and that will require iliac crest graft. Acute lengthening.
Okay. So should
What
I
was-
go ahead?
Yeah.
Okay. So these were the options, and you can see there is a overlap of about that much. If we have to either shorten the ulna or lengthen the radius. So I preferred radial lengthening here, and how I did it is, I'll just tell you. So what I did was I used a cervical distractor, and after doing an oblique osteotomy through the original radius fracture site, I use a Casper retractor and fix the pins over which. So that is the osteotomy. This is the Casper retractor, which is used for distraction of the vertebral bodies when you're doing an anterior cervical discectomy. And then with the distractor on, I distracted gradually. And so that is an oblique osteotomy. After having distracted, I checked the distal radioulnar joint, and once I achieved a desired correction at the inferior radioulnar joint, then I calculated the graph, what was required. And that was a iliac crest graft I used here to fill the defect. And that is how the graft has been impacted and added. Even though I calculated, there was some error. I could not match it perfectly. So the remaining area, I used autograft to fill that and fixed it with a plate. I removed the pin, used a compression plate to compress, as GSK sir has said, and again checked for the ballotment at the inferior radioulnar joint. That was stable post, and this is his post-op X-ray. And this is at 3 months where it's healing up, and that is his wrist function. He can do, he has a fair amount of dorsiflexion now. He can do most of his activities. This is a video he has sent. He lives somewhere in the north where he has complete pronation and supination and a good amount of dorsiflexion, which he wanted after the surgery. And this is the X-ray he has sent at 1.5 years. So this is how, if we could have planned and executed. Any comments?
Nicely done.
Well done.
Good.
But I think this is a little very large operation compared to the
Shortening of the ulna.
ulna would be a simpler procedure, and that's the only thing. Otherwise, either you have to lengthen or shorten the ulna, one of the two. But shortening the ulna would be a very simple procedure. You may be knowing Dr. Tanna had this, and he got operated by Dr. Bindra, and the shortening was done.
This patient was 26 years old, and sir was 50 years older than him.
But then I think at the age has nothing to do with this.
Results would be the same.
Either you have to shorten the ulna or lengthen the ulna, the results would be the same. The only thing is ulna would be a simpler procedure. That's all. Why age should make a difference?
Probably his level of activity, grip strength.
But same thing you could have achieved with shortening.
Shortening of the ulna. As Samir said, probably the grip strength and the range of movement, what they would achieve if you shorten the ulna would be different rather than restoring the anatomy.
Are there any studies like this?
No, I don't know, sir. We don't know.
These are always
In a young individual who is less than 30.
Okay.
Yes.
This is basically related to the radioulnar variance. If it is neutral, then the transmission of force will be more towards the radial side.
So, Vidisha, you have any case for presentation?
I have, but not in collected now. I was not knowing to present a case.
GSK sir, if you have any case, I think we'll be discussing that case. Tanna sir has just landed, possibly 10 minutes, 15 minutes, he'll be joining. So, if you have on laptop, I think we can discuss that case.
Yeah.
Phadke sir, about the plaster,
Yes.
whether in which cases you will give it in pronation and in which case you will be doing it in supination.
I always give it in supination.
And what about the distance? It has to be always above elbow,
Above elbow.
irrespective of whether
Yes,
you
yes.
have done it for a distal third radius.
Even in a distal third radius, I would give above elbow cast.
And what is
And
the
it's
end
different.
point of stacking?
Stacking, there should be no translation and there should be no rotational instability.
But it is a subjective judgment.
Yeah, it's a subjective. You can't be objective in that. The canal gets filled, that's all.
Sir, please go to slide view.
Vidisha,
I know this case,
can you take this case?
but I don't remember the duration.
Doesn't matter. It doesn't matter.
It doesn't matter. It's an interesting
This
case.
patient presented as case of infected non-union with nails in situ.
Yes, as we can see,
Probably a year or so with draining sinus.
On which side, ulnar side or radial side?
Do we have clinical pictures?
No.
Sir,
Okay.
yeah.
So probably the instability is more on the radius side, but you can see the dressing and the soft tissue defect there on the ulnar side.
yes. Even the ends of radius also look like possibly they are infected.
Infected, yes.
Yes.
So, Phadke sir, what was wrong in nailing this? What are the mistakes which have been done?
First is the entry point is listus tubercle. The nail from the radius is too long, and ulnar nail is too narrow. Radius nail also appears to be too narrow. It could have accommodated a wider nail than this. That's all I can say. Whether it was done closed or not, I'm not sure. Because it's infected, so I think they must have opened both the fractures.
Yeah, I think the same.
So the stability is not enough for radius as well as the
ulnar, both.
Okay.
And if they had done it open, then there's no reason why they put such a narrow nail. It's a closed, I can understand, but open, you have to put the largest possible nail that you can fit.
So if you have a reduction like this, will you accept the radius reduction?
If it's closed, I might still go ahead. It will still heal.
Proximally, there is a overlap, there is a displacement.
But it will still heal. With a closed nailing, the hematoma is there, it still heals. With the open, I wouldn't accept it. Not at all.
Chandak sir?
Okay, sir. Any tips on giving curvature or pre-bent shape to nail?
Yes. The radius nail is straight. So you shouldn't use a straight nail. You should give a curvature to the nail before putting the nail inside of it.
So you bend in a S shape or you bend into a C curve?
No, a C curve.
C curve.
And only the tip I bend opposite to the C.
The tip is opposite to C and then there is a C curve. And if you find the bow is not reconstructing, then you turn the nail inside?
You can change the position of the nail till you get the optimum curvature.
Okay, and if you use a very tight and a very well-fitting nail, then turning also becomes difficult.
Yes, but for a closed nail, usually you don't put such a tight fitting nail.
Okay, perfect. Fine.
When you're doing a closed nailing, if you have to improve the reduction, of that proximal segmental radius. How will you do it, sir? Will you do an open reduction? If you are getting, if you are not getting, will you accept that first?
So I see first of all, it's a straight nail, and I won't get such a bad reduction. But I can, if this is the position after nailing with close.
We are discussing this fracture and
Yes,
the reduction.
by close nailing.
Yeah.
By close nailing, if I get such a position, I would put another slender nail by the side of that, and stacking this nail will improve the reduction of it.
Will correct the reduction.
Yes, yes.
Okay. Okay.
And also becomes more stable.
Yes, yes.
Another and second one point is entry point is also should be styloid process rather than the distal radius. Can I move ahead?
Yes, sir.
This was the done.
The middle segment was necrotic.
Yeah,
The
segment was necrotic.
So in this case, only removal of nail and the antibiotic beads seem to be inserted, but no stability. As you commonly present, GSK said that stability also is important for controlling infection. So in this case, that was not done.
Yeah, that's right. See, stability is equally important from day one to the last day of healing.
Yeah,
that's the principle. This was what was done. Vidisha, it is a fibular graft, I think.
Yes.
Yeah, fibular graft and beads also.
So debridement, removal of all necrotic bone, and then stability with a plate and intercalary bone graft. That is what the principle was used here.
And also local beads are kept on.
Yes, and local beads are also there.
Was closure an easy thing? So much material inside.
It was done after 2 to 3 days.
Okay. But as we see here, even though the bow is lost, but the inferior and superior radial joints seem to be quite comfortable.
So the ulna was shortened here, sir?
Somewhat shortened. Maybe a centimeter. Maybe a centimeter.
Okay. GSK, sir.
Oh, yes.
So this is what I was saying. Now, you can see here, the only part of the proximal end of the ulna has been removed. That you can see that U here.
Yes.
So one cortex has been left in which was normal, and the other cortex has been removed.
Yes.
So that is what I was asking a question.
Yes, yes. Yes, if there is a I don't know why this was kept like this, but probably there was this was a healthy bone.
Yes.
Yeah, but then this needs to be filled up with cancerous bone if it is healthy bone. I agree with you. If there is a healthy bone, you can keep it, but then you need to graft it, retain it and graft it.
Sangeet, that was your question when you asked.
Yes,
partial,
I may not be clear at that time.
Yeah.
We often come across a situation where one cortex is intact, or it is a healthy bone, which we retain, and the other side we have to excise it till we remove the unhealthy bone.
Usually, part in contact with the plate is necrotic.
Yes, yes, exactly.
Yeah, that is healthy.
Yeah, this has happened to us in tibia many times. I agree with you that when there is such a thing, we keep it, because to removal of this would be in tibia especially, would be too much of a gap, removing it. But so you can retain this, but you need to graft this then, because this this will not unite with this half this.
And the plate would have required was probably should have been a longer plate.
Longer plate, yes. Now this was done in 2013. You can see here. Probably that time we were not so. That we are now using longer and longer plates because it gives more stability. I agree. Shall we proceed? Yeah.
Yes, sir.
See, again, this was the situation. I think that got infected ulnar side also.
Yeah.
And this was again liberated and put a graft.
No, I
This
think cement block was done.
is a sinogram. What you see by here is a sinogram, but this is the graft probability as you have put. As I told you, that was
The in between X-ray is missing.
see this
One
this
X-ray is missing.
this did not work. This, I think this has to be removed up to here. You have to shorten it or lengthen it, whatever you want to do. But then this needs to be excised.
So inadequate debridement was the cause of failure in this case.
Maybe.
Yes.
So this got infected again with us. With this was patient was outside initially operated, but then we also multiply operated. But then the infection was the only problem which was bothering us all the while.
Infection was not getting cured. In spite of debridement, beads, antibiotics.
Yes.
So then Elizaro came to our help sometimes, in such cases. So the infection continued. And then once this was done, the shortening again was done, lot of shortening.
Shortening was tremendous.
So
but in the upper limb, in the humerus and ulna, in one case humerus, it was very bad case, and we shortened it such an extent, hardly there was this patient had a tall patient with long other arm, and this arm was very, very short. But he was very happy because he could do everything. Even if there is a small arm or forearm, the function is okay. Cosmetically, of course, very bad, but the function is very good. In upper limb, in the lower limb, of course, it is different. In the upper limb, you can shorten as much as you can with good function. So this is what was done after this. And then this was the situation after some days. This was after say 1.5 years or so. Then this was again had problem. So this was repeated.
In between X-ray is missing again.
What was in between anything?
Masculates was done in between. I think. And after that, infection got control. After, I think, after 6 months or so. And then this is the last procedure.
Musculus was done.
So distal and ulna was now excised for getting him pronosupination?
Yes. Yeah, you can see that there is some problem here also.
Yes.
Yes, please.
Yeah, this is, let us see what happened. Then this was the situation. Then he had again some infection, but we removed the plate and got infection cleared. This was the final situation, and I don't think he has
In
got any.
total, some 8 to 9 times he was operated, including debridements.
Wow.
And then this was into 20, that means after 7 years, 2013 to 2020. This was the situation. He has a clinical
He has
photograph.
fairly good hand movement,
Yes.
restricted wrist movement, and restricted pronosupination.
So after 6
He
years,
is having
almost-
some 50 degrees, 50 to 60 degrees supination pronation.
I think there was clinical photographs.
Yeah, I was having photographs.
Sorry.
but then after 6 to 7 years, the whole bone now appears quite quiescent. And
Yeah.
healed
Everything is quiescent. The infection is quiescent. He has shown good function, and he is very happy at the end of.
He is very happy. He comes for visiting every year. He comes just to visit.
So the conclusion would be, it started as a complication of nailing and it healed with plating.
It was complication of infection. I would say it's infection rather than nailing. Nail also, of course, was not done properly. Nail needs to be done properly because there were two things. One, the entry point was wrong. And the second is that the nail was unstable. Reduction was very poor. And nail should be as large as possible. If there is one nail, you can put two nails, but it should be very stable and fixation. So these are, of course, nail was not done properly. That is the cause. And infection. If this patient had not infection, but still it would have gone into an aseptic non-India. Then you have to have a nailing properly. If you do the nailing properly, even in segmental fractures, we have seen fractures have united nicely. But the nailing should be done. Nailing was done outside. Anyway, one thing I would like to say here is I must thank Vidisha for giving her cases to me. Most of the cases that I presented belong to her. She has done all the cases. The initial cases, one or two from that Nepal fellow and these, they were done by me long back. For the last 20 years, she has taken over from me, and she is doing all the upper limb surgery. And finally, this case was also entirely handled by her.
Sir, in the last presentation, you presented a case of synostosis. So any particular inputs for taking that synostosis out?
There are some papers. I would say that because lack of time, I didn't spend on it. The synostosis after post-operative synostosis, the results of excision of this is very good. But then there were papers which were putting fat in between the to prevent further. That was not acceptable. That is, that there are papers who says that whether you put fat or not, it doesn't matter. But then there is a recent paper in which he has put wax, bone wax. And bone wax he has put, and then he says his results are much better than without this. So excision should be done on both sides, and it should be filled up with fat or that is what is the standard treatment. But there is a controversy whether to fill it or not fill it. The very recent paper shows the wax, putting wax in between the two fragments. But the results are good. I'm not aware of the congenital synostosis, what is being done today. But this is regarding the post-traumatic synostosis. Results are good.
Okay.
Chandak sir.
Yeah.
Now, very often we end up in a situation where we have done a plating and a small graft is required. And we have not discussed with the patients about the iliac crest. So in those situations, how do you fill those small gaps? On one side, say there is a defect, will you leave them alone or will you graft them with a bone substitute or graft from somewhere else in situations where we have not taken consent about the iliac crest graft?
Yeah. So if the patient is under block and he is able for a counseling, I think I would tell them that I would need a small graft, and tibial condyle becomes a very useful source, because what you need is a very small amount of cancellous graft. Also, occasionally olecranon, if it suffices, and if the fracture in the forearm is distal, I would use forearm, because in the same anesthesia and same procedure it can be done even without a formal consent. However, I think it's always better to inform them that we are taking a small piece of graft.
So how about distal radius and proximal ulna, Vidisha and Dr. Phadke, sir? Do you?
For the scaphoid, I use distal radius, scaphoid non-union, routinely, because it, through the same incision you can take it. And if it's a forearm fracture and a small graft is required, olecranon sometimes is sufficient, but you don't get plenty of bone from that. Not a very happy situation. So if, as Dr. Chandak says, if you can tell the patient on table and he is ready for the grafting, it is better to take iliac crest graft.
Yeah.
Nowadays, I preoperatively tell every patient that bone grafting may be needed. So it is taken in a written consent as well as video consent. And my anesthetist informs the relatives that we will be doing grafting. So maybe tibial condyle or sometimes a bigger graft than iliac crest in closed fractures.
Chandak sir, your experience with RIA in the cases which have significant large defect. So how is it in a non-weight bearing bone as compared to weight bearing bone?
Unfortunately, I have not used it in any of the forearm bone fractures, because it becomes quite simpler and cheaper and easy to do even with the available bone from either fibula or iliac crest. So I have not ventured for forearm bone fracture with Rimmer irrigator aspirator bone graft.
And how is a plate as an external fixator for radius ulna as compared to the lower limb? So you have been using that quite often.
Yeah, it works excellently. So this case sir showed where infected non-union was there. So what I would do, I would use 2 pins proximally in ulna and 2 pins distally, 2 locked screws, and it functions very well. Rather, patients are so comfortable with the X-fix of a plate, that is the extracutaneous plate as an external fixator. It's very comfortable. Very comfortable.
That would be okay for ulna, not for radius.
Only for ulna I had used, but even for, I think, radius, the problem would be going very proximal. So for radius, if it is middle third and distal third, it is feasible. What you need to use is longer screws. So longer screws should be available in that size, which you have to keep a special stack position. It's a good thing actually. Dr. Negi had used ECPO for non-union of humerus quite often. That he has functioned very well.
Kulkarni sir?
Yes.
You raised your hand.
No. Not for anything else. But anyway, I have used locking plate as external fixator in a large number of patients, and because of infection, it worked very well, because external fixator, the main problem is the pins are loose.
Yes.
And the loose pins are always cause infection, pin track infection. The pin track infection with a locking screw is much less, because the fixation is very good. And that is the reason why it works very well in tibia and femur. It works very well. I have not used in radius ulna because there was no need to do this, because any external fixator would cause pin track infection. You have to remove it and all that. Even then it is, so there is no need for, I think, for in forearm for using the external fixator.
Yeah. So I think that was a wonderful discussion on forearm fractures. And any other question remaining, any thought process? We were waiting for Dr. Tanna sir. He is likely to join within a minute or two. So any other questions, Sangeet, if you want?
So that device, Phadke sir, is it commercially available?
Yes, yes.
The
The
procedure.
Uma Surgicals also is there. And they also have a video of how to use it.
Okay.
Occasional patients I have noted median nerve compression syndrome after use of that distracted. Did you have in your series?
Yeah, in the first 2 or 3 cases, we had intraosseous nerve palsy.
Sir,
So we do a lot of padding for the.
Kulkarni sir, can you unshare your screen? I think in Tanna sir's talk, there is a video of that. Probably it will be easier for you to explain on that. Just give me 2 minutes.
Okay.
So am I seen here?
Yes, we can
Yeah.
see your presentation.
So this distractor for close nailing of radius and ulna was devised by Dr. Phadke and Dr. Kulkarni from Yavatmal and Amravati respectively. So there are other methods of reduction like a manual traction, Chinese finger strap with a overhead traction, and a forearm distractor. Now, this is the principle by which probably Dr. Phadke, can you explain,
Yes,
sir?
sir.
Yeah.
Yeah. See, actually, this is the traction device. It can be attached to the operation table, and 2 fly-nuts. You can control the amount of traction. You can control the position of the forearm also with that. And we can use sterile bandages to tie this. You can sterilize the whole equipment in autoclave if you are really worried about infection. But I have stopped doing it. So you can cover it with the towels and not a problem. The most important thing is the counter traction post has to be padded well. You can't rely on a simple towel to do the padding. You have to use a lot of cotton for that. Secondly, while giving traction, at least till you are used to using this, it is better to see the forearm fracture site under IITV so that you don't over distract. You give only that much traction as is necessary. So then the question of median nerve palsy doesn't occur. And 2 cases it had occurred, but it recovered within 3 weeks after. And usually it's only a partial, that is traction. Yeah, you got a video also. So you can give traction. So this is where you should keep a watch under the IIT so that you know how much traction you are giving.
Yeah. So, Phadke sir, what we get is a good AP view, but getting a lateral is difficulty on a distractor. So
Yes, yes. Lateral is you get about 2/3 lateral view. That is 70%. That is enough for getting a nailing done.
Okay.
You don't require exactly dead lateral, dead AP. AP is very easy. Lateral, I think there must be a photo. Can I share my presentation? There's a photo for that.
I think Tanna sir has joined.
Has joined. Okay. So no.
So partly.
You can share sir's presentation so that you can share his.
Yeah.
Yes, sir.
Welcome, sir.
Hi.
Yeah.
Still on, I am quite surprised.
Yeah. So that was a good discussion going on with GSK sir presenting cases on gap non-union, and Dr. Phadke presenting on forearm close nailing. Vidisha presented on complications and advantages of nailing. So Dr. Sangeet is sharing your PPT.
Yeah.
Is it seen, sir?
Yeah, I can see. The forearm fracture is treated by closed or mini open nailing and open plating, and each one claims superior to other. Nobody is sure what is to be done. But here, nailing not very suitable for such low radius fracture because it will give you a deformity there. But still, I can think that Gadegone will say, I'll put another wire and I'll correct that. So that possibility which exists. Next, please.
You are in the flight or in the car, sir?
Sir, is in car.
Can you change the slide?
Yes, yes.
In a comminuted fracture, it is better to have a plating rather than a nailing. As you can see, it is such a bad comminution. I think the nailing is not a very suitable option for that. Next, please. Now, this is the thin record nail which some people do it. The thin record nail is not a suitable implant for the forearm because it can break down. You need at least a 3.5 DCP in order to get a fairly good implant which can hold on till the time the healing occurs. Next, please. Now you can see here, I will do a nailing probably for this patient today. But this is the one which I was in a plating phase, which I do it, and still I got a very good result otherwise. Now a nailing, only thing which is probably compared to the plating, nailing is inferior because you'll have to supplement with a plaster for at least about 6 weeks or so. While in a plating, you can leave the patient alone. And in about a week or 10 days time, he can start using his forearm for whatever the day-to-day reasons completely. So for a surgeon like you and me, probably the plating may be a better option than a nailing. But still, that debate will continue forever. Next, please. Now, the nailing, when you do so many times in the ulna, probably the nail, the medullary cavity is so thin that you will be able to pass only a thin medullary nail. And that is the one which can bend it, either while giving plaster or if you try to manipulate or anything. Or out of the two bones, if you are really using only one nail, then it is a very poor construct. That also can bend down, as you can see into the other picture. So that's the reason why the nailing has to be done. At least it has to be 2 millimeter. Anything less than 2 millimeter probably is not going to be good enough. Particularly in ulna, some of the distal ulnas, the medullary cavity is very thin in a small females. So that is the one where you'll have to be careful, particularly while giving a plaster. You cannot really put any force which can give rise to a bending of that nail till the time at least the plaster is there. Next, please. Now, such fractures, you will get a malposition. This can be corrected by another wire. It is not all the time which is very comfortable and everybody may not be able to do it. And here you can see this is because of the radial shortening, the ulna is elongated. So in such fractures, I feel you should, even if you try nailing and even if you try a second nail in order to correct this, but if you don't get a radial length re-established, it's worth changing the path and putting in a plate rather than the nail. Next, please. Next, please, Sangeet. Now now the plate is put, but you can see the plate. Also, there are many fallacies. Here you can see the two screws are very near the fracture, and that's the one which has to be completely avoided. No screws can be near the fracture, otherwise there's going to be a problem which is going to be always there. Here, see, it was revised, and when it was revised, the 3 screws were avoided because the fracture was comminuted, and that's the reason this screw. It was a long plate with the screws which are spaced out, and 4 holes were avoided to be plated. Have to be put the screws there, and that's the reason why when you're putting the plate in a comminuted fracture, you'll have to put in a long plate, and unless you put in a long plate, you will have a problem there all the time. Next, please. And as you can see here again, the screw is very near the fracture. If the screw is very near the fracture, it is going to be a disaster, and you may get a complete avascular necrosis of that piece there. So when you are doing a plating, I have a dictum, never a 6-hole plate, minimum 8-hole plate, 3 screws on one side, 3 screws on the other side, and in between 2 screws near the fracture in a transverse fracture, skip them. Don't put any screws there. If it is an oblique fracture, you may have to skip 3 screws. It doesn't matter at all. And if it is possible, you must do the transverse and a short oblique fracture. Next, please. As you can see here, the thing fracture was omitted. Only thing you can see is the screws are longer. This was done quite some time back. Screws are longer, but that cannot give you a problem all the time, but occasionally that also can give you a problem. So the dictum is 3 screws on either side, minimum for a forearm, and has to have a compression with the DCP holes all the time. Your transverse fracture, do not leave it without a compression. And here is a 2-part fracture, fixed always either with a compression DCP or with the leg, never without either of them. So I think either of them you can do it here. Comminuted fracture plate is a neutralization. Adjust all the fragments indirectly in line with the fracture and fix away from the fracture. So do not hold the clamps on both sides. And you see that as you can see here, 4 screws have been skipped in order to get that fracture healing. Next, please. Now, interfrac screw. This is the one which I've been repeating. Short oblique fracture interfrac screw is contraindicated. As you can see here, the interfrac screw is done. Next, please. And you can see it is. Next, please. Pakka non-union, and you can see the sequestrum which is formed. You can see that where the leg screw were there, it has completely become sequestrated, the piece which is nearby. So never a leg screw in a short oblique fracture, you must do a compression. And the long oblique fracture in a forearm is generally not there. It's always a short oblique fracture. To try to do a compression and not a leg screw into such short oblique fractures. Next, please. I have been using this if there is a small bone gap or a comminution. From every drill, from the flutes or from the slit of the drill, and also of the tap, if you have to do it, you can take out a bone graft. Generally, the bone bone dust which is there in this hole, when you are drilling, you will be able to use that. And in this drill sleeve, in this drill, you can see in the slit, you can take a bone graft. So 6 holes, if you use it and you take out a bone graft, is a reasonable amount of graft which you will get, which a small comminution can be grafted without taking any autograft from anywhere else. Next, please. Now you can see again here, this is the one which got infected. And the screws, as I mentioned to you earlier, never the screws nearby. And this is the same thing which I am going to talk about. Otherwise, it gets also infected and you will have a much bigger disaster. Next, please. As you can see here, this can be changed again with the screws on either side, keeping the 2 screws minimum away. Now here you can see, this is a very situation that the patient has radiological non-union. As you can see, still it is not very clearly. Here 4 weeks. Next, please. Which is 10 weeks. Still there is a gap, but the implant is holding. Now it is 16 weeks. No pain, implant holding, but radiologically shows a non-union. Then now you've gone further and further, and ultimately the fracture heals up. So if the pain is not there and the implants are holding with the fracture gap which is seen, that means radiologically it is not healed up. It's a very good chance. I have collected quite a few cases of this painless radiological non-union, but no pain at all, and you hold on for sufficient. There, even if you do a bone grafting, it will heal up. But if you hold on also, that will heal up. This is what I feel is strongly I feel that you just hold on and the fracture heals. Next, please. Now, such fracture will always do a plating. You can never have a sort of a nailing with the trying to compensate with the plaster. So the plating is the most important part for such fractures. Next, please. Sorry, I can't read it on the phone. Can you just read, Sangeet?
Small fragments like this with good soft tissue do not touch. No spikes around these small fragments. They have to be left alone, and you can do a bypass or a bridge plate in this mode so that you avoid devascularizing that small fragments, which are wedge or butterfly type.
Yeah, see, I think this is the most important part. When you do the plating, you don't have to really hold the white bone with two clamps. Only make a small passage wherever you want, keeping the muscles all around so that the soft tissues are not taken away. So the plating doesn't mean that you got to have two white bones in two clamps and then hold them and then put a plate. So that's the reason you will have to maneuver between a small area in which the soft tissues are not disturbed. And more so in such comminuted fractures, you'll have to see that the soft tissues are not disturbed and still you do a plating. It's like a MIPO plating, which we do it with the soft tissues intact. Even open also, you can manage those soft tissues without any disturbance. Next, please. Now, this is the other drawback of a plate. Unless you bend the plate, you will not be able to get the curvature of the radius. Here you can see you put in the plate and the whole radius curvature has been obliterated. So such a plating is also going to give you a mal rotation, particularly the supination pronation will be restricted. So you'll have to get the contour of the radius restored. And that's the reason why you will have to probably bend it and trial and error. You'll have to have a perfect bending, and then only you will be able to put in the plate, particularly where it is in this area where there is a radial bow which is seen. Next, please. Now, this is the non-union of the upper ulna. I feel upper 1/3 ulna is a dicey fracture in these more rigid fixation. This is a semitubular plate, which fixation is not adequate here, and this fracture, it gave way. So that you can see there is a non-union, because this is a thin plate comparatively, and even the olecranon plate is a thin plate, which I think the next case will show you. Next, please. So if this fracture is treated, this is upper 1/3 ulna. This is not an olecranon. You put in a plate on the side so that the screws, you can have a proximal screws, which is a bicortical hold, and that is a 3.5 minimum screw. So I have been changed over to this bicortical plate, a bicortical screw hole, because if you can put in the plate not on the dorsal surface but on the side, then you can have a bicortical hole. And as you can see here, 6 cortices can be fixed on both sides. Next, please. This fracture slowly over the time, because of the non-union, 5 months and 7.5 months, you can see the healing occurring. And this is after 2 months, 5 months. This is the one which you can see the fracture is healed up. It takes a long time once the non-union has occurred. In order to get the healing back to the track, it may take a long time. But if the implants are holding and implants are good, then you can do the function. Patient can carry on with the normal day-to-day activities, and still the fracture will in due course of time heal up. Next, please. Now, you can see this is the one ultimately in 18 months time, radiologically, it is fully united and the patient has got a full function which is there. Next, please. Now, this is a 32-year-old fresh fracture which was treated with the olecranon plate. Olecranon plate for such a upper 1/3 ulna is a poor implant, I feel. It's too thin an implant. So again, the same situations, I took it out and I put in a lateral plate so that I can have a proximal bicortical fixation, as you can see here. And this is in 1.5 years' time. You can see a good consolidation which is occurred. The plate is long enough, almost the 4 screws on either side. And this is the one which is, I feel the olecranon plate should not be used for these upper 1/3 fractures. Olecranon plate is good enough into the cancellous bone. But once you come to the cortical bone, you should use a much thicker plate like 3.5. Next, please. Infected Talwaka square nail. Now, this is the one, as you can see, it appears to be a lysis all over. And even outside, you can see there is going to be a reddish which is there. This is after 2 years. So the infection occurring after 2 years is comparatively uncommon. Some of you will not even know this, but in those days when we used to do this metal, it used to give a metal reaction. This is the typical metal reaction which you see. You can see here the dust, black dust which is coming out. Next, please. And you can see this black dust which has come out of that, and the part of the nail which had broken down, which was removed. I couldn't remove the whole nail. So ultimately that dust and everything was taken out, and the remaining part which I had scooped it out, which was really destroyed by the metal reaction, I put in hydroxyapatite and I had to come out. But this is the one which I think you'll have to be aware of, particularly if you're seeing the old cases where the metal was not of that good quality. And you can see this is the typical metal reaction which is there. Next, please. Again, this is as you can see here, the metal reaction. Next, please. Yeah. This is again the metal reaction. Still, in spite of the reaction, the fracture is healed up. This is another metal reaction. So this metal reaction we used to see it in older implants very much. But nowadays, when 316L, which is being used by majority of the things, and even if you use an LBM now this sort of a metal implant reaction we don't see. Next, please. Now, this fracture, there is often associated with the scaphoid fracture. As you can see, it is missed. So unless the joint above and joint below, which we all know there is a dictum, but we don't do it all the time. Here, the scaphoid fracture was there, which was fortunately picked up, and then it could be fixed up with the screw. And obviously, the long or comminuted fracture was fixed up with the plate. So you got to have this one X-ray of the joint above and joint below, which we always talk about. But again and again and again, we see this missed fracture in the above joint or a below joint. Infection. This is Dr. Sushil Sapni's case. Next, please. This is the fracture which got infected, cleaned it out. Next, please. Cleaned it out, washed it out till the time antibiotics, and when everything healed up, then you can see still that discharging signs appear 2.5 months after the whole debridement. And this is the bone operative picture after removal of the plate and scraping of the granulation tissue. Next. And this was the operative picture showing the viable bone after the debridement. Next. And there was a bone gap which was there, then ultimately it was filled up with fibula. This is the standard treatment which we all do it. Next, please. And slowly over the time, the fibula get 10 months post-op patient without plaster. And this is, you can see it heals up with some amount of supination pronation, which is going to be compromised in such a fracture. The 10 months post-op patient without plaster for last 4 months, positive ulnar variants, ulnar shortening can help. And so in this sort of a fracture, if the patient has a problem, you can use an ulnar shortening. This was another patient from Nepal admitted in the fracture both forearms, 2-year-old, again infected, long gap. Next, please. Long gap, you can see everything is infected. Pus there. So the infected bone is excised. There is a big gap which is there, you can see. And the surgeon has done the Aliza Rao fixation, X-fix fixation with the fibula graft, and slowly over the time with the wires and everything, slowly over the time the fracture heals up. But obviously there is going to be some supination pronation which is going to be defective. So these are not my cases, but I have my few of the people who have sent me. This is what I'm showing you. Next, please. Another case, both the infected things with the big gap there, Aliza Rao, segment transport, and they still the people can really get the union there with the segment transport, both the bones. So in conclusion, yes, nailing and plating both works in this indication. Radial bow is important. Do not put screws in one hole on either side of the fracture. Infection needs multiple surgeries. Thank you very much.
Thank you very much, sir, for making it, even though you were landing from the flight. Thank you so much. Any questions?
If any questions, I'll answer. Otherwise, that's fine.
So, Sangeet, any questions? Vidisha, you have any questions to sir? No. I think the whole spectrum of forearm fractures were very well covered in this today's meeting, from nailing tips and tricks to complications and advantages of nailing. Sangeet took the lecture on plating and difficult complex fracture. GSK sir gave very good insight into gap non-union, and ultimately we had complications in forearm fracture and various perspectives from Tanna sir. That was a meeting which gave everything about the forearm fractures. Any final comments, Sangeet? Then we'll close the meeting.
GSK sir and Tanna sir are not acknowledging each other or admiring each other.
I go in.
we acknowledge every day morning, so there is no need to acknowledge in the presence of.
We don't do that formality.
Dilip, what has happened is we had discussed all points in detail with Sangeet pointing out some common complaints. So there was no question for you.
Good. So I have repeated what you have discussed already.
No, many good new points, sir.
No, anyway, that's fine.
Yeah.
No issue.
Perfect.
Thank you very much, friends.
Okay. So
Thank you. Thank you all for joining.
Thank you, Dilip.
Yeah. So
We'll meet in MOACON now.
Yeah.
We'll meet on MOACON. Yeah.
Sure.
Dr. Shinde.
Hello.
So final word from you, and then we close down. Shinde?
Yes.
Yeah.
Vote of thanks.
Yeah. So curtain was raised at the beginning, and now you have to close the curtain.
We waited for Dr.R.M., but I think Dr.R.M. has not joined. He was busy.
No, he gave his lecture. He gave his lecture. Yeah. So thank you.
I thank.
Dr. Karne was busy. He could not join, but everyone has joined, and Dr. Gadegone conveyed that yes, the whole webinar has went very well. So we designed the webinar from 10:30 to 1:30, and we have almost finished in time. So thank you, everyone, and we'll close this webinar. Thanks, everyone, for joining.
Thank you.
Dr. Joining. Thank you. Thank you. Poonam, you can stop streaming.
Stop recording.
Yeah. Poonam, you are there?
No, it has not been stopped.
Yeah, I'll just ask them to stop and then we'll close.
Sangeet, you raised very nice discussion points and questions. It made it more lively.
Yes.
Very, very good questions and very good discussions also we had. Very nice.
I had to extract from you, sir, because you don't share otherwise.
No. In a 12 minutes, you can't.
Yeah. I think we have to leave because there's no one at their end to stop recording.
Oh, Poonam was there. I think I just messaged her.
Poonam, are you there? Sir has asked to stop the recording. Poonam from OrthoTV.
She's not responding. Probably we'll have to leave.
Okay.
I'll do that. No problem.
We'll stop ourselves and go.
Yeah. No, I'll do that. Don't worry.
Okay,
So, thanks and
Bye.
thank you very much.
Thank you.
Enjoy the Mahalakshmis today.